Good morning. My name is Brent Wood. I'm a faculty member at Azusa Pacific University School of Nursing, and I'm fortunate to be the chairperson of our Research Symposium webinar faculty committee. Later in our program, you will see the names of the distinguished faculty and staff who have worked so hard to make this webinar possible today. This is the 16th annual School of Nursing Symposium, but only because we had to cancel our 2020 symposium due to the COVID-19 a little over a year ago. So it should be the 17th. At that time, of course, we had no concept of how far-reaching this deadly virus would become. And this past year has indeed been a time of pain and sadness for our country and for our world. As I've explained to my students, no other single event in the history of our lives has shown the spectrum of care that begins with individual patients and extends to social policy. This year, our symposium webinar has 3 sessions. In these sessions, we consider how this pandemic has impacted healthcare systems, along with nursing and public health education. Qualitative surveys will provide research data in the name of science. The testimony of nurses, patients, professors, and students will bring the passion and visceral reality of the sadness and the hope that exists even in the midst of such great loss. We are a Christian university committed to the total health of patients and communities with a priority on social justice and a particular concern for underserved populations disproportionately impacted by this virus. The planning committee selected a Bible verse from the book of Deuteronomy that resonated with our planning and the nature of the experience that we want for all of you today. Moses was giving instruction to Joshua, the leader who would succeed him and lead the emerging nation of Israel into an unknown land of uncertainty and hostility. And these were the words that he gave them. He gave to Joshua that day. Be strong and courageous. Do not be afraid or terrified because of them, for the Lord your God goes before you. He will never leave you nor forsake you. To honestly assess the impact of this virus, it's important to acknowledge the pain and loss and the fear and the death of so many. But pain, loss, fear, and death are not the last words. We believe the Lord our God goes with all of us and will never leave nor forsake us. We hope your experience today will provide encouragement and hope as you continue to navigate in this difficult season. It's my pleasure to now to welcome our Provost, Dr. Rushclan Fernando, and then we will follow with our welcome by Dean Lesh and continue with our invocation to begin our program today by Dr. Cheryl Tyson.
Thank you so much, Brent, and thank you for that opening. And indeed, it is wonderful to be with you this morning. And, I've been on so many Zoom calls during this moment in time of pandemic, and this is a record. 513 participants. From my understanding, I think over 900 people have registered for this incredible event. And I want to thank the faculty and the staff, as well as Dean Ayalesh, for organizing this event and for the incredible work that goes into organizing this event. And I want to sort of reflect also on some of Brent's words from that book from that quote from Joshua. And I think one of the things I want to just relay back to you, especially to our partners, to our faculty, and to our students, that I have indeed seen your strength and your courage, that I have indeed seen some of the things that God was telling Joshua as they were thinking about moving into that new nation, that new place for the nation of Israel. And so you represent the incredible resilience, the incredible hope that happened despite the difficulties that we experienced in this pandemic. I know it's been a very, very difficult year for each one of you. You have engaged and dealt with unmanageable kinds of situations professionally, personally. So I pray and I hope that today, as you engage in a research symposium, that this would indeed be a time of intellectual, personal rest for you to engage in important topics of research in the area of nursing surrounding this pandemic so you can be equipped to do your work better. Again, I just want to also speak to our students that are participating today, first of all, saying that we here at APU are incredibly proud and grateful to call you our students. And again, thank you for the faculty organizing committee for the incredible work that you do to take care, to engage our students, to provide them with that holistic education. So with that, I'll pass it on to the next speaker. And again, have a great day, and thank you for inviting me to give this welcome. Take care.
To extend a warm welcome to nursing and public health students, faculty, APU nursing alumni, and our community partners who have joined us today for the annual Nursing Research Symposium. This is the first time we have celebrated the Research Symposium as a virtual event, and we are excited to be able to bring to you today an opportunity to hear national and international speakers discuss the impact of the pandemic on a global scale. 2020 was one of the most difficult years in recent history, unparalleled in terms of economic impact, loss of human lives, devastating illness, and unrest. To be a nurse or healthcare worker, even in the best of times, is a difficult, stressful job. But 2020 and the early part of 2021 showed us just how difficult that work could become and served to highlight the importance of nursing care and public health measures in order to safeguard the health of the nation and that of the world. It also focused us on the importance of research to inform the actions and the critical role of leadership in order to implement the actions and the changes. The Research Symposium this year explores the impact of the pandemic, not only on the population and the economy, but on patients, care providers, educators, and students. The coronavirus brought into glaring focus the gaps in our public and acute healthcare systems and the deficit in our research and leadership. Our entire healthcare system is in need of transformation, and research is the tool of discovery that can inform that transformation. As the importance of healthcare research has grown, and as the importance of improvement in patients' care has become visible, we now need to look at research to inform that process. We must all become actively engaged in making decisions about our own healthcare and the practice of nursing. Information must be available and informed by research. All of us must own the importance and the duty to contribute to the development of a body of knowledge that improves healthcare. To effectively build new knowledge, the research process should be developed within a theoretical structure that proposes approaches to healthcare and facilitates the interpretation of findings. Research without theory tends to result in a disinterested and discrete elements of information that does not translate well into practice. Theory helps to identify the meaning and clarify the relationships of theoretical concepts. The purpose of this symposium is to foster intellectual curiosity, refine critical thinking, and improve clinical reasoning for nurses and those in the healthcare professions. APU School of Nursing is committed to creating a dynamic learning environment and to support evidence-based practice. The Research Symposium celebrates the passion that many of us feel for research and the development of knowledge to improve patient outcomes. Florence Nightingale supported her nursing decisions through effective data gathering to illustrate the effect of nursing care on health. Her use of statistical data changed the healthcare system of her time. We too can change the healthcare system of our time. It is my sincere hope that you will enjoy the conference and develop an excitement for healthcare practice that is informed by research. To become inspired, to integrate research knowledge into practice, and to shape the future of healthcare.
Good morning. My name is Dr. Cheryl Tyson. I'm the Associate Dean for Research in the School of Nursing, and it is my honor and privilege to say a prayer for all of us. This prayer was given to me by Dr. Elaine Gaynor, who was not able to be here with us today, but she is with us in heart and spirit. The title of the prayer is A Prayer for the Tired, Angry Ones. God, we're so tired. We want to do justice, but the work feels endless, and the results look so small in our exhausted hands. We want to love mercy, but our enemies are relentless, and it feels like foolishness to prioritize gentleness in this unbelievably cruel world. We want to walk humbly, but self-promotion is seductive, and we are afraid that if we don't look after ourselves, no one else will. We want to be kind, but our anger feels insatiable. Jesus, in this never-ending wilderness, come to us and grant us grace. Grant us the courage to keep showing up to impossible battles, trusting that it is our commitment to faithfulness and not our obsession with results that will bring in your shalom. Grant us the vulnerability to risk loving our difficult and complicated neighbor, rejecting the lie that some people are made more in the image of God than others. Grant us the humility of a decentered but beloved self. As we continue to take the single step that is in front of us, Jesus, keep us from becoming what we are called to transform. Protect us from using the empire's violence in our words, in our theology, in our activism, and in our politics for your kingdom of peace. Keep our anger from becoming meanness. Keep our sorrow from collapsing into self-pity. Keep our hearts soft enough to keep breaking. Keep our outrage turned towards justice, not cruelty. Remind us that all of this, every bit of it, is for love. Keep us fiercely kind. In your precious name, amen. So thank you again, and I want to again extend my thanks to Dr. Gaynor for providing us with that so very appropriate and beautiful prayer. Now I have the pleasure of introducing our first speakers, Dr. Marian Lynch and Professor Elena Villasardo. First, a little bit about Professor Villasardo. Dr. Villasardo is from Portugal, where she earned the title of Specialist in Nursing and teaches courses in interprofessional communication at the School of Nursing in Coimbra, I think, Portugal. Her accomplishments include completion of the Joanna Briggs Institute Systematic Review Training Program through the Portugal Center for Evidence-Based Practice. Joanna Briggs Institute is an international research organization based in the Faculty of Health and Medical Sciences at the University of Adelaide, South Australia. The Joanna Briggs Institute develops and delivers unique evidence-based information, software, education, and training, all designed to improve healthcare practice and health outcomes. Professor Villasardo has also co-authored a number of publications, with her most recent being Effectiveness of Educational Programs Using Diabetes Conversation Map Tools on the Health Outcomes of People with Type 2 Diabetes. Our second presenter, and they are presenting together, is Dr. Marian Lynch. Dr. Marian Lynch has been a registered nurse for 37 years, so she has 37 years of experience. She has a well-developed understanding of current and social care issues and policy development and expertise in implementation internationally, nationally, and regionally. Her mission is the development of a new disruptive model of community-based care delivered by networks of organizations that address population health and prevention in partnership with patients and professionals. Her recent work includes, for example, improving global health fellowships with the Ministry of Health in Zambia. The objective of this initiative was to provide a process through which the quality of healthcare could be coordinated and improved through the country. She's also introduced this using the World of Health Framework for Quality, which identified the top 6 no-cost or low-cost interventions across the life course and care continuum. Dr. Lynch has also worked with Primary Care International, where she was a clinical associate. She's worked with the World Health Organization and the Ministry of Health in Jordan to establish management of national non-communicable disease strategies and operational plans for stratification of hypertension and healthcare staff training for use of risk charts. She's also most recently co-wrote e-learning modules on COVID-19 in low-resource countries, leading on medical health of healthcare staff. So with that, I would like to introduce our 2 presenters, Dr. Lynch and Professor Vilasardo. And the title of their presentation is The Lived Experiences of European Frontline Nurses Under the Shadow of COVID-19, Emergence of a New Type of Nurse Capital. Thank you.
You're muted.
Helena and Lynch, you can go ahead and unmute if you'd like.
Hello. I can't believe I'm unmuted after being a year on Zoom. I'd just like to be able to share my screen. I can still see Dr. Tyson. Would it be possible to share my screen, please?
Yes, is it not allowing you to do so?
No, not at the moment.
Okay.
My screen is... Okay.
You should be able to do it now.
No.
Horace,
Hello,
let's go ahead and can we make Lynch a co-host for the moment, and let's see if that allows it, because I'm able to share as a co-host. Yeah. So let's go ahead and make her a co-host to see if that'll help.
Okay, all right. Can you share it now? Okay, you should be able to.
Marion, we might want to have you log off and log back in. That may reset whatever's happened there. I'm not exactly sure why. And maybe we can have Helena give a quick introduction or something.
Maybe I can try to share.
Yeah, see if you can share, just so that we can make sure that the settings are working correctly.
Yeah. Helena, if you just go, then I can speak to yours. Okay, that might be easiest. Let's just do it that way. You start from the beginning.
Yes.
Hello, everybody. Apologies for that technical hitch. We are speaking to you from England, which is a country off the edge of Europe, and from Portugal, which is within Europe. So we are international and yet connected with you. And we're connected with you as nurses as well as academics, because I think the key here is to understand the common experiences that we've had as nurses in the past year and the common ideas about what we can do to go forward. So just to put our study into one slide, on the next slide, I just want to show to you that our aim of our study was to examine and compare the lived experiences of European nurses from 9 countries during COVID. Our design was a descriptive qualitative study, constant comparative method. And Helena will talk about that too, so that we can tell you what was going on. And our sample was European nurses who were at the forefront during COVID across the care continuum from every avenue of nursing. And they were members of one Sigma group in a European chapter. And the inclusion criteria was that they were members or connected with a Sigma member, and they were working in a COVID context, not out of work. They were English speaking and writing. So before I go in, I'll just tell you the story of why this started and how come I'm the one speaking at the moment. Helena, the next slide, please. So when the pandemic hit, I was in New Zealand, which is completely the other side of the world to England. And I was isolated and trapped there because England closed down and New Zealand shut its borders quickly. Now, fortunately, as a nurse, I was given a place on a European plane to come out as long as I acted as a nurse on the plane, and was flown into Europe and then got to England. And within 48 hours, I was working at what England called the Nightingale Hospital. So on your screen, you'll see the top picture is a conference centre. And this conference centre was turned into a hospital in 9 days. It was a hospital to accommodate 5,000 people who were intubated. Now, as a nurse, you'll appreciate that a conference centre is not a good place for people who are intubated, and nor is it a good place for people to work. The sound is terrible. There's not enough toilets. There are no sinks. And so this was a very different way of working. It was built in 9 days, as I said, for 5,000 people, and 500 beds were ready to go when I arrived. And I was one of the trainers to teach people how to look after somebody who was intubated in an exhibition centre. And in 4 weeks, we trained 3,000 healthcare staff and other staff to provide some level of care. And I tell you this context because this was a huge political piece of work. It was launched by politicians, it was led and built by the army, and it got celebrity status. It was featured on the news every day. The people who were working there got presents and chocolate. And I felt terrible because the nurses I knew who were working in ordinary hospitals had to turn wards into ITU places and were getting none of this. They weren't even having enough protective equipment. And they were having death rates way, way over what we were going to be having. And they weren't enough critical care nurses. Already we have a 40,000 nurse shortage. And this political construction became the ultimate British insurance policy, but nurses saw it as something very different. And as I spoke with my colleagues who were nurses around the country, they were in their cars crying when they came home because they were too scared to go into the house. They were too worried about what other people were going through. And our politicians were putting all of the money into these big events and systems rather than supporting the staff. And I started to think, is this going on everywhere? Is this the same in every country? England has a national health service, so it's state run. And usually it works well. And we have a good community where people step up to be volunteers. But I was really, really worried about my nurse colleagues as I saw them getting sick, some dying of COVID, and mostly lots and lots of glory going to these big politically supported hospitals, but nothing in the rural areas. So I spoke to my colleagues in Europe as we were going through all of this, and I said, is it the same? And we said, we don't know, but we think so. Why don't we ask the nurses? And that's where this came from. A group of us from across countries in Europe decided to ask the nurses. And we did this in a practical way. But before I tell you how, I want to give you the research framework that I wanted to use. Can you go to the next one, please, Helena? Before I spoke, we were talking about resilience, and we held on to the idea that resilience is an ordinary aspect of the human condition and a basic component to any stable system. It's not something that needs to be sought out as extraordinary. It's part of a system and it's part of what nurses do. And the sociological concepts I wanted to look at was Bordeaux's ideas of culture. Now, their idea of culture isn't the music or the arts or anything. It's the bits of our world that we don't necessarily see or we can't count. And the capital aspect of culture is what we own in terms of our skills, our behaviors, the symbolic elements. So for instance, a nurse capital is made up of the field that they work in. That's the appropriate knowledge and the status they have that's accumulated, exchanged, or monopolized by others, the power that comes with that, but also it's made up of the habitus, and that's called the collective identity and group position. And I was thinking that nurse capital has really changed in COVID because we were working in areas where nobody had the knowledge about what to do. I was in an exhibition centre. I'd never nursed in an exhibition centre. We were working in roles that were unfamiliar with people who were unfamiliar, different teams every day. And also our identity as a nurse was covered physically with our PPE, but also somehow had changed in society. There were heroes and angels and these very unhelpful tropes and messages that were going on at the same time as stigma and people moving away from nurses in the street because they didn't want to get COVID. So people like us aspect came to my thinking. Next slide, please. So the context and the sort of theoretical context I wanted to start to look at resonated with resilience again. And this was because in order to strengthen a health system, we need the system and the staff. And when I've been working across Africa, recognizing there's no point training all the staff up if the systems are failing. I also, after so many years in nursing, recognized how the nurse voice is missing in many policy development, in a lot of politics. And that nurse view on what was going on and what is going on is often missing. And yet in COVID, the nurses came to the fore. They were designing the services, redesigning the pathways, having conversations with patients and really taking a lead and using their intelligence that sometimes was squashed to shine a light on what was possible, stepping into areas that they always knew they could be in, but because the system wasn't allowing it, had been prevented from doing so. The other side of that is that nurses already have the highest occupational stress, and we had some really serious staff safety issues, particularly with at the beginning when we had quite a lot of nurses dying. Previously, we've always had an issue that nurses felt their mental health was being ignored. And as the rush to the pandemic hit a year ago, physical health was addressed, but mental health was noticed. We wanted to do our psychological PPE, but nurses were on the front foot and working hard and not yet exhausted. It didn't take long till nurses were exhausted. So our environment was changing and the choices that nurses were able to have on their own health were changing. And this kind of theory is called a resilience dividend. And I think nurses were part of this concept of resilience dividend that had never really been discussed before. So the idea of cultural capital from Bordeaux and the idea of a resilience dividend were the two theories that started to get us thinking about what is happening, rather than just stories of what's happening, what's going on here. And this is why nurse capital came to the fore. Next one, please. So this is my last slide to tell you what we did then. So you can imagine working across languages, across countries, across a pandemic. And we decided to go through our Sigma colleagues to seek out nurses who were working on COVID areas. So we stipulated that we would invite them to provide 150 words and one picture explaining what they were doing, and also provide consent that we would be able to share that narrative and that picture to inform future thinking about nurse identity, nurse skills. And firstly, we weren't overwhelmed with this. You know, Europe is a 600 million people, we weren't overwhelmed. People, I think, were too busy and wanted to know where this was going. When we reiterated that this was about shining a light on what nurses can do instead of shining a light on what nurses can't do, suddenly we got the stories and people were very, very keen to share their experiences. And they were completed and sent to us. All of the contributors were female. They were all collected in May and June 2020. And then the content was analysed by 2 independent researchers in 2 different countries. And the outputs from this really started to resonate with both my personal experience. I wasn't one of the analysers, but also with the evidence that we'd seen as to what was happening across China, across Europe, across America. And so what we want to do is share with you those findings and the key themes, just see if they resonate with you as well. And more importantly, where do we go with this information? What do we do with this now? Research for research's sake, a bit like art, is okay. But I think research that will ensure that nurses stay in the decision-making field, stay at the policy making, stay at the front, not only with the patient, but with the policy making as well across Europe, so that we don't go back to a silenced voice. I think that's one of the opportunities that we have now. So I'll hand you over to my colleague in Portugal, who will now tell us all about the findings and the themes that came from it. I will then finish with our conclusions and an update on the situation in England and the conference centre, and a thank you picture of all our nurses across Europe who contributed. So over to you, Helen.
So good morning. And after the analysis of these 18 narratives resulted in one overarching theme and 5 categories: the healthcare systems, the nursing care, the nursing competences, and also what do nurses experience as challenge and opportunities that this pandemic brought to them. Now I'm gonna, for a better comprehension, we present each category together with the discussion of the findings. So at healthcare system, nurses highlight some challenge that the healthcare system had to face and even promote significant changes in the organization of care in order to continue provided care to all people in parallel to the paths and service and support that were created for all people infected with SARS-CoV-2. So coping with the COVID-19 pandemic constituted a big challenge to the health system, concerned the deliver to the safest care possible for all the country. And while the investigation occurred about the virus spreads and what were the best treatment, health systems must introduce new measures and do a reorganization to adapt to the new circumstances due to the SARS-CoV-2. And this was above all the biggest challenge for the health system, changing while the knowledge about the virus and COVID were developing at the same time. So making chance to maintain accessibility to health care for the entire population. But on the other hand, they had to take cautious measures to lead to a decrease in the spread of virus. So nurses' assistance was given hospital-wide. Nursing wards were converted into COVID wards. So many needs to reorganization at institutions. All of this implies creativity and innovation in healthcare providing. So healthcare system had to reinventing new ways of caring. And the main focus, if you remember, at the moment was the improvement of interventions on respiratory system as ECMO and ventilatory assistance. And as this informant tell us that a respiratory skills team was created to give expert support in respiratory management in all units of this hospital. And also another informant mentioned the creation of PPE safety officer that helping ensure that workforce were supported in donning and doffing PPE correctly and safely. And also new routines, new rules were created, mainly the restrictions of a lot of persons on the clinical context, reducing or forbidding the visits to all the patients in the clinical and social context too. And to patients as no visit, but also to nurses was a different rules because nurses have to change their routine to get in and leaving the hospital with a series of rules that they must follow. And of course, these measures affect all health sectors and consequently the entire population, since support is limited and dealing with the fragility of the health system itself. For instance, the need to get hospitalized in an institution far away from home due the lack of beds. And this informant was talking about the patient in health and life. So he had to get far from home to get hospitalized, and there's no palliative care institution to receive him. Looking at the literature, it reveals throughout history, major pandemics have generally led to significant organizational change. And especially in healthcare system, these changes are reflected in all organizational levels, at the policy, at organizational goals and objectives change, procedures are adapted to a new reality, new guidelines are formulated and strated, and also new ways to translate the policy into practice. Ferruccia and Plotowski also found on their study that the search for creative solutions for issues that arose during the epidemic led to innovations in clinical and managerial practice. So the response to the response to the pandemic has created opportunities for collaborations and partnerships between different professions and industries, and also between all the countries in the world. In the nursing care, we know that patients with COVID-19 are characterized by having long periods of hospitalization and recovery and rehabilitation periods. And during pandemic, nurses focus only in COVID, and most important focus was COVID. Even so, nurses kept the essence of nursing care, taking care not only of the person, but also of their family members. Due to the distance and no visits allowed, it was very important to people know that their relatives was well cared. As we can see on this quote, that children was seeing mom through the window and just say, dressed well, looking well, she's well. So nurses also developed new strategies to providing care. In health promotion and disease prevention, nurses were active on social media, reaching out to a large proportion of people. And when providing counseling to affected vulnerable patients and relatives at home, new strategies were used as well. Nurses utilized online, text message, and video calls. And they felt that COVID-19 had contributed to a rapid development and use of communication through telenursing. Although in some situations, a video or phone call could not take place between healthcare provider and, for instance, a deaf person. So one nurse available for response for individuals with disabilities during pandemic is a lifesaver measure. It's the case of this informant 5. So the results are in line with recent studies that emphasize taking care not only of the person, but also of the family, for whom it is important to know that their family member is being well cared for and they do not die alone is the main concern of families. Rogers, in their study, a recent study also, reported on a similar way that nurses felt like a resource, a guide, and source of emotional support related to self-concept. So besides the pandemic and all restrictions at nursing care, nurses remain centered their caring on patient and family. About the nursing competences, nurses described that their professional and personal competence, along with the nursing code of ethics, were of the utmost importance when dealing with the corona pandemic. And at the professional competences, they mentioned the leadership. The leadership skills were about being able to handle unforeseen situations, about being able to design, implement new policies. So, as we can see in this statement, that for nursing specifically in the 2020 as the year of nursing is the time to reinforce that the nurses could expand the role of healthcare leaders and ensure that people that they look after feel safe and cared for through this pandemic. Another professional competence was teaching or educating or just using the voice of the nurses, especially to contribute to the dissemination of information to general public to stop the spread of the coronavirus. Experienced nurses also using their experience they got from their clinical work to teach students and new nurses. And one our informant is a university lecturer, and she says that she returned to the hospital to help on the COVID pandemic, and she talked to us that this experience is very valuable for her to prepare nurses for the work and the current and the future disaster too. Teamwork, it was another issue very highlighted with emphasis on work in multidisciplinary teams, particularly visible on shared decision. They felt closer to every member of nursing team and also from other professional workers, as we can see in this statement. The team united as never before I felt, nurtured and nurtured others. So it was like a feeling of belonging. Another nurse's professional competency was contributing to patient safety, because in this the 2020 year of nursing, we confronted a serious public health problem, and it's the time to prove once again the value of nursing for the health and safety of all. At the personal competences also described as valuable in their professional work, and mentioned the flexibility, being flexible in nursing care referred to handling the corona pandemic as the new normal, accepting new ways of working and new rules, and everything that was provisionally taken for granted and routine changed quickly. And they had to adapt to caring for very vulnerable patients. As we can see here, from one day to another, these nurses became a head nurse of one of the COVID nursing wards. So this requires that some nurses had to refresh certain skills, and also that experienced nurses quickly had to provide training for less experienced nurses. Empathy was also described together with flexibility and resulted in nurses deviating from their protocols when assisting relatives to say goodbye to their close ones. And also, nurses described the innovative to improve new ways, new strategies to keep caring, particularly to the elderly patients in isolation, and try to improve some ways to remain these elder people engaged in social activities. And resilience. The resilience was the watchword. and to support all change, readaptations, and continue to care for others, even in moments of immense tiredness. And this is mirrored in this sentence that says, they worked hard, help to defend state. Also, the nursing code of ethics was related to patients' rights and dignity and equality, which must to be maintained even in disasters such as during the current pandemic. That many patients lost their lives due to COVID-19 and took a toll on the nurses as they fought for every single life and still trying to providing holistic care, but made difficult by scarcity of personal protective equipment. So all this nursing competence allows to nurses to break the rules with security, but keep care in a holistic way. And the magnitude, such as the pandemic by SARS-CoV-2, it implies readaptation, and at a personal level, healthcare workers ready to work in a new format, a new experience, acquire new skills, and face new difficulties, and also demonstrate agility and flexibility. And this is what the literature says to us. While the leadership had been raised in our study, a recent study cited gaps in nursing leadership during COVID pandemic. Delhi considered that, Delhi 2020 considered that nurses did not have a voice strong enough. Their interests and concerns regarding nursing have largely not be addressed. So, and it happens, for instance, at Portugal. And it seems that while at the personal level, the participants did feel a sense of leadership, at the general level, the nursing leadership maybe doesn't not act. Teaching practice and dissemination knowledge on clinical practice was an important confirmed competence to nurses. And at nursing education, nursing students cited professionalism, courage, and humanity for their teachers. Although the lack of knowledge and experience was a difficult to educational, the people in general, and particularly to improve nursing education. Regarding to teamwork and team spirit for medical teams during COVID-19 pandemic, the collaboration has been expressed in the words such as, we are all in this together, camaraderie is everything. So it's similar to Goldman and Chirik's, our findings that reported on positive process of collaborative interprofessional working among teams, including physicians, nurses, respiratory therapists, cleaners, whatever. Our participants reported trying to do their best according to the code of ethics. On the other side, as reported by Robert et al. 2020, the imbalance between utilitarian and individual ethics led to unsolvable discomfort for caregivers and raising ethical dilemmas. And also, for instance, the prioritization of COVID-19 patients on the basis of first come, first served, it was ethical dilemma to nurses. Well, talking now about challenge, we identified challenge on nursing care, on emotional management, and professional risk. So the major challenge in nursing care was identified by nurses as lack of research, communication difficulties due to equipment and restrictions, as the masks and the visors make communication hard, although they still keep caring, dealing with the uncertainty in making decisions and acting while knowledge is starting to develop. Dealing with this challenge allowed nurses to identify new challenges to the future as the keeping and gaining visibility. So keeping the visibility and gain new visibility. and the need to evaluate the effectiveness of all measures taken while pandemic to maximize future preparedness. Emotional management was also a challenge to nurses. Nurses felt social discrimination by family, by neighbors, and those in society who identify them as nurses working on the front line. As the nurse says, we became social outcasts. And neighbors, knowing where nurses work, wave hello from afar and take a giant steps back as they park the car. Caring during the pandemics triggered negative feelings in nurses like fear, uncertainty, anger, anguish, stress, and tiredness. As some nurses says about COVID, it isolates you, it scares you, and for some, it kills you. Nurses designated the COVID-19 pandemic as a professional and human test, a baptism of fire, the biggest challenge in nursing. So this demonstrates the nurses' perception of the pandemic and further corroborates all the feelings mentioned. Working on frontline is living with the professional risk of get COVID. And nurses knew that COVID-19 does not choose some people, it can eat everyone. It is not, in fact, a disease that develops only in persons from certain risk groups, as said it in this statement. And also the injuries for using protective equipment is a professional risk. So these challenges for nursing care are in line with literature. The shortage of staff, ventilators, and personal protective equipment has been reported in different countries around the world. Moreover, similar communication barriers between patients and nurses due to personal protective equipment were reported. Historically, epidemics went together with stigma and discrimination, and similar to the current study, medical workers in Wuhan, China, who dealt with COVID-19 outbreak faced discrimination, isolation, patients with negative emotions, separation from their families, and burnout. Working in this condition led to healthcare workers getting mental health problems such as stress, anxiety, depressive symptoms, insomnia, and the professional risk reported by the persons in this study, the study of Barello, says that 71% of healthcare professionals agreed with the statement, my job is putting me at serious risk. But the pandemic did not only bring bad things, bring also opportunities. The nurses in this study described an increased visibility of the nursing profession, a raised awareness of the nurses' contribution, leadership to the health system, and more politicians' awareness of the nurses' unique contribution. This pandemic brought also visibility to other nursing care contexts. In the year of the nurses, COVID made the visibility of nurses' work bigger than expected. The positive reactions from public emphasizes the recognition of value of nursing for the community. During the pandemic, people flooded with affection message tributes every day to all the professional healthcare providers. The stories provided even exact citations from public as superheroes. Working in a challenging work environment has led to development and growth among nurses. Nurses had reflections on different look upon life in general and personal decision making and prioritizing in particular. Has this statement, this has turned me into a better person, an experience that could make me appreciate life, so I choose to live every moment by tuning in on emotions. Or this have shaped me. Is a simple statement that shows the development, the personal development. One other interesting finding was that nurses recognize their own value and contribution, thus promoting nurses' professional self-esteem. Nurses highlight the union and pride in their own profession. We were united and we managed to do our best, and proud of myself, and I am proud to be a nurse, or I have never been as proud as I felt on this journey. So there's a number of scientific reports and examples for the popular media on this positive experience of nurses from around the world. And during the last year, especially at the first wave, nurses and nursing care were represented in media on all the levels of pandemic response to COVID-19. Nurses are the real heroes is the slogan that became viral in social networks. With one onset of the second and third waves, that the expression diminished and were replaced by images of nursing teams tired of the ongoing workload of dealing with an epidemic. Despite the immediate positive effect, questions also arose about the long-term implications of this hero enthusiasm. Throughout history, nurses were portrayed as heroes in times of crisis and wars. And McAllister and Brian and Dean affirms that this short-term positive atmosphere can overshadow acute problems of the profession that are not adequately addressed. For example, the inadequate working conditions for nurses. About the findings of professional development and advancement on nursing care as a consequence of the pandemic, there's no clinical studies was founded. But Fernandez did a review on nurses' experience during a pandemic, and that shows that the main change in the role and the function on nurses were related to clinical skills and managerial and leadership abilities. So this must be the development in this competence. So it was this, and our findings talk of everything that Marion talked before about the resilience and all the doubts that we had. And it was very, very interesting to do this content analysis with my colleague Jan from Sweden. And the most interesting thing is that in this methodology, we recounted a story based on the contribution of 18 narratives. And it was invaluable when we shared these results and interpretation with the members of the community, the committee communication at Sigma Europe. And they said, this is it, that's how I feel. It was amazing because we felt that our mission was very, very good accomplished. Just as a curiosity that with this narrative, we ask also a photo, an image that illustrates the narratives and the lived experience that nurses were passed with COVID. And we can say that indeed, the most chosen image to represent the experience of nurses during COVID is the nurse with the personal protective equipment, almost irrecognizable, and to represent teamwork. Thanks. I pass to you, Marion.
Thank you. Can you go to conclusion page? Thank you. I hope that the findings are familiar to you in some ways, and I hope they're not familiar to you in some ways, because it's been a hard year for many. And the conclusions that we come to, we suggest that these accounts show that nursing care continued across the life course and the care continuum, and nurses made sure that it adapted to COVID, and they adapted to COVID. But somehow COVID made invisible nurses visible, even though we were behind protective behaviors and protective shields and hidden away from people and isolated from our families, in the wider world, we became visible. It also made new nurse roles and responsibility and the regard that goes with them, the capital, viable. The things that we were told that nurses couldn't do before suddenly became absolutely necessary. And so the idea that you can't, because of protocol or lack of whatever decision a decision maker decided, all went away, and the responsibility became viable. The opportunities became viable. But we have a question to ask now, because this research has shone a light on not only our expertise and our experience, but where we go with nursing now. So has COVID made nursing about the vital safety skills and leadership, and taking it away from ideas of vocation and virtues? Has COVID created a case for change for how nursing is seen, the identity of nurse, the gender specific, the class specific, the skills specific, the uniform, the ward based, that kind of thing? Has it moved us educationally to think away from competencies or capability to this idea of capital, of how we're able to work in new spaces without any kind of prescribed knowledge, because we need to work with the tacit knowledge that we've got and work in that complex place? And has it created an opportunity to reorganize this nurse identity, to change the practice or the policy of recruitment, retention, and all the other elements that go with being a nurse? And somehow, is this going to change nurses as individuals and change nursing as a profession in a way that will address some of the challenges we have about recruiting nurses, about regard for nurses, about the responsibilities that nurses are able to take on and flourish with as a profession? The next one, please, Annette, Helena. So we go with the final statement from one of our international leads, Annette Kennedy, who is president of the International Council of Nurses, who says we still have challenges, but we can surmount those challenges and we can work together to build a better future for nurses and patients. We can't wait for the opportunities. We have to create and make the opportunities. We cannot wait to dream, and we cannot wait to wish. We have to do it, and we can. Each one of us can make a difference, but together, 27 million nurses can change the world. And in 2021, we can start to see that change, and the future is in our hands. I've been a nurse what feels like all my life. I've worked internationally, and I'm a nursing professor now. And nursing is going to flourish whilst I'm still in it. But somehow we need to address where the power is in the conversations and in the policy. So, Helena, if you just go past all of the reference pages, because as academics, we've given you all the references and the links are active. I've checked them all. And I want to give you an update to just show you what we're up against. So I introduced the Nightingale Hospital, and built in 9 days with the Army, and the fact that I'd say in the UK, we've had just under 130,000 deaths of COVID now. That Nightingale Hospital treated 54 people, trained more than 2,000. That was flight attendants, retail workers, as well as critical care nurses, physiotherapists, dental people. All the people who could no longer work in their own jobs came to be trained in some kind of 2-day program for emergency care. But it ran for 1 month, April the 8th to May the 16th. There were 7 hospitals set up in the UK for this. This was the one that was most active. In total, we saw 272 patients. It cost £532 million to set up, run, stand by and decommission these. That's over $530 million. And our nurses in the UK have just been offered a 1% pay rise, which is under the rate of inflation. Unsurprisingly, we still have vacancies And we still have a long way to go to recognise that nurses aren't the heroes. They are the safety critical people who saved many lives outside of the Nightingale hospitals, in ordinary homes, and will continue to do so in the next pandemic. But we need nurses to be there in order to do it. Thank you very much.
Should I stop the sharing?
Yes, please. And back to you, the hosts, for question and answers. I will take the question and answers.
Thank you. So I wonder, Bridget, if we have some accumulated questions from our attendees.
We don't have any questions yet. This is the opportunity. If you have a question, you can use the Q&A feature to type your question in.
Thank you.
Whilst the questions are coming, I had a student nurse with me many, 4 years ago. She was in her A-levels deciding to be a nurse. She decided to be a nurse after spending a few days with me. Her first qualified job was in intensive care last year, April last year. And she's a family friend. And she, at 22, witnessed 3 deaths of people under 50 who were well the week before in one day. And when she got home, she couldn't get out of the car. It makes me emotional talking about it. She couldn't get out of the car, and her mum, who she was living with at the time, came out and sat in the car with her until she had finished crying, and her mum cried with her. And then it was, okay, now I'm okay, I can go back. And she continued that job for 9 months, and she's now left nursing. And there's something there that we need to recognise, that this was a young woman in her first year who saw more than I've ever seen in my 37 years of a pandemic in her own small town in a Western country. And unfortunately, hopefully she'll come back to nursing, but at the moment she's working in a health system administrative job so she can regroup herself. And I think there's a lot of people now in that situation.
All right, thank you, Dr. Lynch. It's got to be so challenging. We do have some questions. Bridget, are you going to share those with us?
Yes, Dr. Lynch, can you tell us what your greatest lesson was as a nurse researcher during this pandemic, and what have you learned during the study?
My greatest lesson learned as a researcher is it's really good to be in there, to be in the cold rooms, watching what's going on, but being a participant observer as well. In the theory, we call it work as done rather than work as imagined. And I think because I got the cough from being in the cold, I got the exhaustion, I lived on sandwiches, I cried with those people. It resonates with me, the reality of the situations. So that's the sort of researcher bit I've learned. I've also got a bit bristly about politics because I was very whilst having experienced that and then undertaken the research, to have politicians speak of more nurses in the system and more money in the system and all of this stuff that does not resonate with my experience and my findings and the theory. I worry that we'll go backwards again, and that's why that's why I'm here, because that can't be the case.
Thank you, Dr. Lynch. I have another question. I'm wondering what your perspective of the nursing student role was overseas during the pandemic, and what did you see? What was that like internationally?
I can speak from a practical UK perspective and some of the international global South happened the same. Our nursing students were finished their training 6 months early and were put into qualified status and put onto a register where they worked. And nurses pay a lot of money to train and then have to provide free work hours whilst they train as well. But they were put 6 months early into the system, as were doctors. And we had huge worries about safety, but also recognizing that they hadn't finished their training, they hadn't celebrated an end, they hadn't had that closure. You know, they'd been planning a whole 3-year program, they had dissertations to do, and they were doing nights as a qualified nurse on a COVID unit. So they have suffered as a result of this. We had record numbers of people wanting to come forward to train as nurses. So something has gone on. However, we already know that we have a record number of people leaving during training and leaving during the first 2 years of qualification, even before the COVID element. So I think students relished the opportunity, absolutely stepped up, but have lost out on the end of their training and the celebration element and the closure of much of their learning.
All right, I think we have time for one more question, Bridget.
We have a question regarding the Nightingale Hospital. Several people want to know, why so little amount of patients, and were the citizens of the UK made aware?
Oh my goodness, I'll do it in 3 minutes because you will know the answer. The reason so little, that there weren't enough nurses to care for them. The idea that you can build a hospital without a workforce is a political idea, not a practical idea. And there weren't enough nurses to go. So what would happen is if you wanted to transfer a critically ill patient who was intubated into the Nightingale, you had to have their nurses come with them. And those nurses, those critical care nurses, were already overseeing 2 or 3 nurses who weren't critically care trained, but who were looking after patients in ITU. So they couldn't be released from their own host hospitals. Therefore, the patients had to stay where they were. So the very few that we got, I think it was 27 souls were lost, and we had only one person who went into a discharge situation, because we had no discharge lounge or anywhere to get people out. But that's why it was so few. And every nurse in the system was saying, well, who is going to staff these? And we were training people to staff them in our training unit, but they couldn't be released from the hospitals that they were already working in. Of course, they were already overfull with people with COVID.
Well, thank you both for this presentation and for the quality work that you've done. I see some of the participants expressed a hope that that study could be done in other regions in the world. But it helps us get a better view of what's happening in England and other parts of the country. Clearly, both of you have a great passion and have provided some great insights as a result of this research. So we're so grateful that you could be here. It's the first time for us to have someone from England and Portugal. I wish that we were all in person so you could hear 1,000 people clapping and expressing their thanks, but it's coming through loud and clear in the chat. So with that, we will transition to Dr. Milky for the introduction for our next speaker.
So thank you.
Good morning, everyone. I'm Ruth Milky, the Associate Dean of Faculty and Alumni at the Azusa Pacific University School of Nursing. But first, I want to reinforce the thanks to Dr. Lynch and Ms. Belizardo for your presentation today. The outputs of your research on European registered nurses really reinforces the pride of being a nurse that COVID has engendered worldwide, but also the work that nursing has to do as a profession yet. So thank you for taking the initiative to take on this important topic, doing the timely work, and then sharing it with us today. We are most grateful. So now I have the privilege of introducing you to our next speaker, Dr. Marnie Kellogg. Dr. Marnie Kellogg received her BSN in nursing from Northeastern University in 1998, her MSN, specializing in nursing education from Salem State University in 2011, and a PhD specializing in nursing science, health promotion from the University of Massachusetts Lowell in 2017. Congratulations, 2017 is not that long ago,
No.
right? I know you're still can't believe it, right? Good for you. Dr. Kellogg has worked as a pediatric nurse for over 20 years and in nursing education for over 10 years. She's also a certified pediatric nurse and certified nurse educator. She's currently tenure track assistant professor in the Department of Community Nursing at UMass Dartmouth. She has presented already her work at local, regional, international conferences. She has publications in Pediatric Nursing, Journal of Pediatric Nursing, other peer-reviewed nursing journals. Her primary interest is traumatic stress in nursing. Currently, she's working with colleagues from psychology to explore the impact of COVID-19 pandemic on nurses. So I'm happy to present Dr. Marnie Kellogg as she shares with us her work on nurses on this side of the pond, the very timely topic of the impact of the COVID-19 pandemic on nurses in the United States. We welcome you, Dr. Kellogg.
Thank you very much. It's an honor to be here. I'm going to share my screen and hopefully this works the way I intend. You never know really with Zoom. Okay, so hopefully you can see my full slides and not my notes pages. Please, if someone could tell me if you're seeing the notes pages.
You're doing great, Marnie.
Okay, great. Thank you so much. So thank you very much for the introduction and thank you for having me. It's an honor to present my research so far on the impact of the COVID-19 pandemic on nurses in the United States. So we just got to move my little Zoom bar so that I can advance my slides. Okay. All right, so I am presenting my research today on behalf of my team, Dr. Anna Scherbel-Schur and Dr. Brian Ayatt. My research before the pandemic was on stress in nursing, specifically pediatric nursing, but when I realized the impact of the pandemic and what that could have on nursing stress, I obviously broadened my population of interest to all nurses. I knew to have a strong study, I needed help, and I reached out looking for some psychology expertise. I was lucky that I also was able to find some statistical expertise also in Brian and Anna. We are from the University of Massachusetts, Dartmouth. A little bit about our university. UMass-D is part of the 5-campus University of Massachusetts system. UMass Dartmouth is located in southeastern Massachusetts near New Bedford, a famous whaling city from the 1850s, and about 60 miles from Boston. UMass Dartmouth enrolls about 8,000 students and is located on an over 700-acre campus. The architecture of the university is unique, mostly very cold concrete, but it was designed by one of the United States' leading architects of the modernist era, Paul Rudolph, in 1963. So that's a little bit about where we come from. So the outcomes for today's presentation are first to explain the impact of the COVID-19 pandemic on nurses in the United States. Second, to examine the preliminary evidence of the prevalence and severity of traumatic stress and functional impairment in nurses working during the pandemic. And then to identify the need for support for nurses working during the COVID-19 pandemic. So the COVID-19 pandemic has placed unrelenting press and stress on healthcare systems as over 141 million worldwide have become infected with the virus. I checked those numbers today. You have to keep updating them. The Pan American Health Organization, which specializes in international health, it's an international health agency for the Americas, reported in September 2020 that COVID-19 has infected some 570,000 healthcare workers. Research in MERS, the Middle Eastern Respiratory Syndrome, and severe SARS severe acute respiratory syndrome has shown increased mental health symptoms in healthcare workers, and psychiatric professionals warn that this can happen again. As we know, COVID-19 has caused and continues to cause an unprecedented number of hospitalizations and deaths in the United States, increasing nurses' physical and nurses' emotional workloads. Nurses juggle many responsibilities, including caring for patients with varying needs, working with interprofessional team members, and addressing families' requests to help patients achieve the best outcomes. Nurses are affected by the scarcity of resources while coping with the risk of contracting COVID-19 or transmitting the disease to their families. Working during the pandemic, nurses and other healthcare providers are at risk of developing psychological distress, according to the American Medical Association. In fact, psychiatric professionals warn about the potential devastation of the COVID-19 pandemic on healthcare providers' mental health. Research examining the mental health sequelae of COVID-19 in China suggests that healthcare workers caring for patients with COVID-19 experienced elevated depression, anxiety, insomnia, and psychological distress, particularly among workers from hard-hit communities. Nurses working on the front lines during the pandemic may be vulnerable to secondary traumatic stress, witnessing the trauma of their patients, or other psychological diagnoses like post-traumatic stress disorder or acute stress disorder. So our study had 3 aims. First, we were interested in determining the preliminary evidence of prevalence and severity of secondary traumatic stress of nurses working during the pandemic. Then we wanted to compare the relationship between secondary traumatic stress and functional impairment between nurses caring for patients with COVID-19 and those who did not care for patients with COVID-19 to determine how this stress is impacting patient care. Finally, we aim to explore the experience of nurses working with patients with COVID-19 through qualitative written responses. So to do this, after obtaining IRB approval, we sent out 2 online anonymous cross-sectional surveys, one in July of 2020, the second in November of 2020. So all of this was before vaccinations were available. And we're planning to send out another survey in a few weeks. So it will be interesting to compare the data with some vaccinated nurses as well. The surveys included demographics, mental health screening questions, a functional impairment measure, and an open-ended question. We used snowball sampling via social media, the Sigma Theta Tau discussion board, and posting a survey link to the American Association of Critical Care Nurses Participate in Research Studies webpage. Valid and reliable measures were used, including the secondary traumatic stress scale to measure secondary traumatic stress. The brief inventory of psychosocial functioning was used to measure functional impairments. This tool looks at impairment in family, friend, and romantic relationships, as well as work and day-to-day activities. And we also use the distracted practice scale to measure distraction in practice in our nurse respondents. Distraction while working as a nurse can, of course, lead to error. Our quantitative sample consisted of 218 nurses. The average years of nursing experience was 15 years, working full-time about 37 hours per week. Our sample was overwhelmingly female and 90% white. The majority were bachelor's prepared nurses. 79% of the respondents had cared for COVID positive or suspected COVID positive patients. 75% of these nurses screened as having moderate, high, or severe secondary traumatic stress in the last week, according to the secondary traumatic stress scale. 118 nurses answered our qualitative item, and that really surprised me because it was at the end of kind of a long survey, but people wrote and wrote. So I do think that they wanted to share their experiences. The qualitative item asked to, quote, please share a personal experience with a COVID patient, including the circumstances surrounding the event. So it was very open. The average years of nursing experience of those qualitative respondents was about 15 years, and they worked on average about 38 hours a week. 75% reported to be staff nurses. And again, this sample was overwhelmingly white and women. The majority of our sample was from the Northeast United States, where we are, 58%. 7% reported to be from the Midwest, 18% from the South, and 16% from your region in the West. 59% of the nurses that responded to this qualitative question felt they had access to adequate PPE while caring for COVID patients or patients who were suspected to have COVID. Quantitative data were analyzed using hierarchical regression for each outcome measure, either distracted practice score or the score from the brief inventory of psychosocial functioning. The first step in the regressions included gender, education, the average number of hours worked per week, the number of years as a nurse, and if the respondent cared for patients with confirmed COVID-19. The second step added the secondary traumatic stress scores. The model accounted for about 45% of the variance in distracted practice scores and 39% of the variance in psychosocial functioning scores. Secondary traumatic stress predicted a significant amount of the variance in distracted practice and functional impairment. In fact, adding secondary traumatic stress to the models resulted in treating patients with COVID-19 to become non-significant in the final model. This suggests that secondary traumatic stress can explain the relationship, or might explain the relationship, between treating patients with COVID-19 and psychological functioning and distracted practice. Qualitative data were analyzed using content analysis. 2 researchers, a nurse and a clinical psychologist, analyzed the data independently. Triangulation was used to enhance the study's validity. A third researcher reviewed the statements and coded the themes. The 3 authors discussed and agreed on the themes, capturing the essence of the nursing experience during COVID-19 in the United States. The authors identified 6 themes, so I will review those now. The first theme was absence of patient-family presence and the need for additional support. Nurses were impacted by the lack of family support and presence, as many hospitals restricted patient visitors to stop the virus's spread. While caring for COVID-19 patients, nurses struggled to provide support and often felt compelled to fill families' voids at the bedside. As one nurse stated, quote, "It's a lot emotionally to be a nurse, family, and clergy for patients." Nurses experienced sadness and distress related to the lack of family support for their patients, as evidenced by the following response. "I was floated to an ICU. I had previous critical care experience. Seeing critically ill patients wasn't a shock to me, but I was very sad for the patients and their families not being able to physically see each other. I just tried to reassure the patients that their loved ones were there in spirit and to think of us as an extension of their family." Furthermore, nurses had additional responsibilities to use technology such as smartphones or tablets to allow patients to see their loved ones, provide updates to family, or facilitate goodbyes as patients came close to the end of life. As one nurse recalled, quote, "A patient of mine passed away very quickly. I had to FaceTime his wife and show her the deceased body while she talked to him. He had already passed. She was very angry and sad at the situation. We lost 60 residents from COVID. The families couldn't see their loved ones or say goodbye. It was heartbreaking." The second theme found related to personal protective equipment concerns regarding safety and how that PPE impairs the nursing role. Several nurses expressed fear that limited PPE and changing requirements for that PPE would increase the likelihood of contracting COVID-19 or spreading the virus to their families. One nurse said, "The stress is high. I'm terrified I'll make a mistake in PPE and I'll get COVID, or I'll be too busy to notice the small changes in COVID patients and they will tank." Another described how PPE makes nursing care more difficult. "The patient that sticks out in my mind is someone who was on high flow and borderline getting intubated. He was so scared during that time. I had him. I tried to comfort him, but of course it didn't help. I was in full PPE and his family wasn't allowed to visit. One nurse voiced the time it takes to put on the protective equipment could mean the difference between life and death for patients. Quote, donning and doffing all of the PPE is what I struggle with the most. Losing precious time when a patient needs CPR and everyone has to gown up. I know it's necessary, but when you see it day in and day out, it's disturbing. The frequency and intensity of COVID-19 related deaths also affected nurses. Our third theme was patient death. Several nurses disclosed that COVID-19 patients they cared for, even young patients, were rapidly dying and were often alone at the time of their death. One nurse stated, quote, I had a patient that was doing okay, sick, but okay, COVID positive. Around 5 p.m., sitting up, eating dinner, being assisted by a CNA. At 9 p.m., he went into respiratory distress, and by 9:30 p.m., he was dead. Another said, I've pretty much tried to block them all out. We've only had 2 patients get off the vent. Nearly everyone has died. One nurse wrote about increasing her own risk to prevent a patient from dying alone. I remember the first COVID death I witnessed. We had extubated the patient knowing he would not make it. Everyone exited the room. I looked at the poor man all alone and sat down next to him. The lead physician said, get out of the room now. You're needlessly exposing yourself to harm. I looked at the man and looked at the physician and said, I disagree. There's nowhere else I need to be more than right here. And I stayed with him until he died. What an honor. Nurses caring for patients with COVID-19 reported feeling helpless. They expressed wanting to do more to help their patients and described how it was often beyond their control to change the virus's rapid fatal course or the conditions for patients as a result of it. These statements fell into the theme of helplessness. It was 2 or 3 shifts in a row when the same thing would happen to different patients. Patients would suddenly require the max of oxygen. Then I'd come back the next shift and there was no major plan to help them. Just keep them on the max and hope for the best. Another nurse stated, it's so scary to watch them struggle to breathe and not be able to help them. The nurses' connection between patients and families also impacted nurses' sense of helplessness. One nurse articulated the feelings that result from not being able to help patients. Quote, my first COVID patient, a young male, had young kids who would visit him from outside. They made him 2 signs, one each saying something along the lines of, get better and come home. I taped him to the window so they would know what window was his. I'll never forget sitting at the desk charting when his heart started to brady down. By the time we all gowned up and started compressions, all I can remember is looking at the 2 pictures in the window. For 68 minutes, I looked at those pictures, and for the first time in my career, I felt like I had failed on every platform possible. I have lost other patients prior and after to this particular patient. It comes with the job. Yes, I'm sad, but I don't let it get the best of me. But this one, to this day, I think about constantly and rethink the events that led up to that code. Nurses voiced the notable lack of preparedness for the pandemic, which was labeled on several levels, including specific units, hospitals, and the country. One nurse described, we all worried how extensive our shortcomings were with language barriers, inexperience, lack of resources, etc. The patient was just an unfortunate combination of hoping we were doing enough, knowing we could have done better in different situations. It was a horrifying feeling to live through for months at a time. One nurse described working as a volunteer in a homeless shelter for COVID positive individuals. The large hospital in my city deemed them stable, so they were not admitted. However, these were patients with respiratory compromise, extreme hypertension, with coexisting substance use disorder, on multiple psych psych treatments for opioid use disorder. These were not stable patients. They had nowhere to go. Watching them sleep in army cots in a high school because our city, our state, our country had failed to give them a decent place to live outside of COVID, let alone during a pandemic, gave me nightmares. Finally, many nurses felt overwhelmed with the quantity of work during the beginning of the COVID-19 pandemic. They were so sick, it took every ounce of energy to keep them alive. Another nurse wrote, working 10 weeks in the ICU caring for COVID-19 patients was an experience that I hope I will not have to repeat. There were many sleepless nights, worries about catching the virus or giving it to my husband. At times you feel alone because you are so tired mentally and physically. Our results showed that treating patients with COVID-19 places nurses at risk for developing psychological problems, namely symptoms of secondary traumatic stress and post-traumatic stress disorder. Moderate, high, or severe secondary traumatic stress affects 75% of the nurses who we surveyed. Secondary traumatic stress may explain the relationship between treating patients with COVID-19 and impairment across multiple domains of life. Nurses who provided care to COVID-19 patients were more likely to experience distraction in their nursing practice and suffer symptoms of impaired psychosocial functioning. This means there is a potential impact of working with patients with COVID-19 on nursing care as well as the nurse's home life. These findings were supported by qualitative responses that stated providing care to patients with COVID-19 is physically and emotionally taxing for the nurse. These results should be interpreted within the context of the following limitations. Qualitative data were gathered using an online method where nurses wrote their responses to an open-ended question. Data could have been enhanced through interviews with nurses caring for patients with COVID-19. However, written responses were an efficient way to explore the phenomenon, as nurses may not have been willing or able to take the time to participate in in-depth interviews given their increased workload during the pandemic. Second, nurses who were more impacted by COVID-19 may have been more likely to write a response or complete the survey. Third, the sample was overwhelmingly white and did not evenly represent all areas of the United States. Thus, results might not generalize to nurses from different United States regions or racial backgrounds. Our study finds that there is a need for adequate personal and institutional support for nurses to prevent and treat distress associated with working with patients with COVID-19. Overall, nurses working in the pandemic are experiencing symptoms of trauma, which may be worse for those providing direct care to COVID-19 patients. Caring for patients with COVID-19 involves a direct risk to the nurse. Thus, the nurse may be experiencing symptoms of post-traumatic stress disorder, not secondary traumatic stress disorder, but that could shift with the vaccines as well. Regardless, it is important to address the mental health of nurses, as a healthy nursing workforce is vital to the health of patients and the community. Nurses are resilient and can overcome this challenge with the help and support of appropriate leadership. So I would like to acknowledge the American Association of Critical Care Nurses for their assistance in posting our survey link on their webpage. And also, if you are interested in participating in our next anonymous survey or nurses, please don't hesitate to reach out to me. My email is here, mkellogg with 2 L's and 2 G's at umassd.edu. And then I have my references. That's all. Here are my questions.
Thank you, Professor Kellogg. I have a question regarding the study. Did you come across statistics as to whether or not nurses left the field or retired during this traumatic stress?
So we did not collect that data with our first 2 survey rounds. However, with this next round of surveys, we're looking at intention to leave the profession, because we do feel that it's likely that nurses are probably leaving because of the stress in their profession. But we did not ask about that in our first round.
Any more questions?
I have a comment and a question. It says hospital administrators could have been more helpful, maybe. Many nurses were denied time off to rest and to recuperate. What do you think could have been done better?
Well, I have never worked in hospital administration. I think that that's probably a challenging role where you can't really do anything to make everybody happy, right? You know, it's a pandemic. We needed nurses. So I think it's really a balance of trying to recognize who really needs the most support, and perhaps providing support in other ways than time off from work could have been helpful. But again, I'm not an expert in nursing administration.
Dr. Kellogg, our last question is where students utilize more in your area to keep up with the workload. I'm assuming there's talking about maybe research students or doctoral students.
Or are we talking about nursing students as they graduated? That's how I'm interpreting it. So in Massachusetts, the state of Massachusetts did allow graduate nurses to work before they took the NCLEX, you know, as they used to years ago, when the waiting period to find out if you passed the NCLEX was much longer. They did allow graduate nurses to work in a graduate nursing role during the pandemic, to help increase the number of nurses. I'm not sure if they're still allowing that or not. I haven't heard that it's changed, so I think that they probably are. But that is one way that they help to increase the nurses in our area.
And from one nurse researcher to the next, I have a question from a nurse researcher that would like to know if your slides are available.
I can certainly provide my slides. If anyone is interested in any additional information, you could certainly send me an email.
Thank you.
Mm-hmm.
Okay, is that the last of the questions, Bridget?
Yes.
All right, well, so it looks like we'll have just a little bit longer of a break. We have a number of people assembling, and they may not be available until the designated time, which is 10:15. So as you take a few minutes for your break, I want to give particular recognition to Visiting Angels in Glendora. They're our platinum sponsor, and have contributed for a number of years to support our research symposium. During the break, you will see some PowerPoint slides cycling through that provide you with some information and talk about some of the people that have participated. And I want to thank Dr. Kellogg and all of our presenters so far. And I want to tell you that the panel that you will experience at 10:15 following our break will be a very meaningful time. So enjoy a few minutes to yourselves, and we look forward to seeing you back here at 10:15.
Hey, Brent, did you want to share the slides that you prepared? Horace has got it.
Yeah, I sent them to him, and he actually put them on a timer. He's such a great guy, because I didn't have them timed. Did you get that, Jeff?
Yes, we're good.
Okay, hopefully you are all back after that break. And thank you, Horace, for your excellent help with the technology. As we transition, just before we transition to our next part of the program, I want to point out a couple of things for you. Today, we do have over 700 people in attendance, and a number of students have been asking questions about how their participation and attendance will be confirmed if they were in the YouTube live stream. Each department will be communicating with you about that. So don't be stressed. We will have a way to confirm that you were actually participating today. The website, the School of Nursing website at APU is where you want to go to get information. That is where the YouTube links will be for all of the sessions. That's also how you access the virtual poster hall, which we'll be looking at from 12 o'clock to 1 o'clock today. It's where all the registration links will be for the upcoming, the remaining meetings that take place on the 27th and the 29th of next week. And especially those of you that are wanting to do the continuing education evaluation forms, that's where they will be. We will be sending a survey to all participants following the April 29th final session. And we see the importance of feedback and research throughout the day, and we hope that you will make sure to respond and participate in that survey. We genuinely want to provide the best possible learning experience for all of you. So I'm very excited and thankful to be able to introduce to you Dr. Valerie Joy Smith, and I'll just turn it over to her, and she'll talk with you about what the next part of our program will look like.
Wonderful. Thank you so much. I have the precious opportunity to take us even farther in our journey of exploring this lived experience with persons who have lived that front line by introducing a panel of welcomed members of the healthcare team. In there, we're going to find a patient, we're going to find a nurse, we're going to most certainly hear from some nursing students, and we will be hearing from a chaplain who has lived this experience and continues to work on that front line. So it is my absolute delight to really further expand what we've been hearing about, and most certainly with Dr. Kellogg, as she was sharing about that 16% that she was able to get some insight from their experience on the Western Seaboard. You are going to hear it as it's unpacked live in this particular panel. As we do that, let me share my screen. We are going to be talking about the lived experience within the local context, given the pandemic. And I'll have the different people introduce themselves. What we're going to do as we go through this session, and by the time that we are done, you will be able to really look at these impactful experiences. What are the different members of the healthcare team saying? You'll be able to identify a faith or a spiritual concept that has been critical to the holistic well-being of all the persons that are involved. We will be able to determine key elements that support effective patient-centered care, which is something that we hold very near and dear to our heart. And you'll be able to propose at least one takeaway from what you hear that you will be able to incorporate into your practice moving forward. So let me stop. And at this point, what I'd like to do is have the various members of our panel introduce themselves and give a little context of where they're coming from. Yolanda, why don't you start?
Oh, good morning. My name is Yolanda Castro. I am the executive director of a nonprofit organization that works to connect job seekers with employers. And I'm one of the earlier individuals who contacted COVID in March April of 2020. So I'm here today to share my experience as a patient in the system and dealing with COVID-19 and the pandemic.
Jen?
Hi, I'm Brenda Simons, and I am the Director of Spiritual Care or Chaplain at Methodist Hospital in Arcadia. I've been at the hospital working as a chaplain for 41 years, so have seen a lot of changes in healthcare. And this experience, of course, is different than anything I have seen in all, in all those years. I am an alumni of Azusa Pacific, both in the undergraduate and graduate school, and I have a deep love of the school, but also of the work I do in terms of working with staff and caring for patients.
Jennifer?
Hi, my name is Jennifer Pay, Jen, and I am a critical care nurse and charge nurse at Huntington Hospital in Pasadena, and I have been there for about 23 years or so. I am also an alumni of APU, and I also am an adjunct professor currently with critical care in the undergraduate program.
Thank you. Okay, our nursing students.
Hi, my name is Brooke Hearn. I'm a senior nursing student at APU's traditional undergraduate Bachelor's of Science in Nursing program. And I worked as a student nurse extern at a hospital in Southern California, working with non-ICU COVID patients.
Hello, my name is Rochelle Roman. I'm in my last semester of nursing school, senior, and I worked in COVID ICU during December all the way, COVID ICU from December all the way till February. Thank you.
So let's get started. Keep your mics unmuted. So let's get started. What impactful experiences stand out, having gone through and lived through and are still going through this pandemic? Yolanda, how about you starting?
Okay, like I mentioned, I caught COVID in late March. I work in an office, and there were 4 of us who caught COVID at the same time. 2 of us ended up in the hospital. When I was sick, I was feeling sick. I had been traveling throughout to Sacramento back and forth. I'd been in San Francisco the day before. They closed San Francisco. So we're not sure where it impacted our office, but 2 of us ended up in the hospital. When I was feeling sick, the last thing I wanted to do was go to the hospital because I had been seeing on TV everything that was going on in New York. And I thought, I can fight this from home. So after a week of not feeling better, I called my doctor. I tried to get tested for COVID. I spoke to 2 teledocs, and I spoke to my office, and no one could get me tested because I never got a fever. I was having a hard time breathing. I had a headache. I felt like my head was going to explode. I had body aches, but I never got a fever. Eventually, I lost my taste. So after trying, I cared for my mom when she was sick, so I knew there was a little device that you could put on your finger to test your oxygen level. So we tried getting one, couldn't find one. So Palm Sunday, I asked my husband, can you take me to the hospital? I don't think I can fight this on my own. So luckily for us, we know several people in the medical field, and they said, take her to Huntington Memorial. Take her there. They're a test site. Take her there for care. So he took me there, got to the hospital. He said, I'll be right back. They wheeled me in. He said, I'll be right back. I'm going to go park the car. Before he could get back, they admitted me. And when he came in, he said, where is she? And they said, we're admitted her. You know, he said, but I didn't get to say goodbye. What's going on? And they said, all you can do is wait. The doctors will get a hold of you. Go home or wait in the parking lot. The last thing I remember is a doctor telling me, you're going to be ventilated. And then I was out. So when I think about the most impactful thing for us is I had it easy. I had COVID, but I had no idea what I was dealing with. I don't remember anything other than the doctor telling me that, but my family is the one who was the most impacted. My husband sat in the parking lot. I still cry when I think about this because I think about their stories. He sat in the parking lot for 6 hours because he didn't know what to do. And finally, my daughter said, "Dad, come home." They brought him something to eat. They said, "Come home. We'll wait to hear from the doctor." So it was on his way home that he got the phone call that said, "She's pretty bad. We don't know if she's going to make it, but we're going to do everything we can to help her." So he pulled over and he was beside himself, went home. But, and it is, I mean, when I hear their stories about what they experienced and what they went through is when I really realize the severity of what I was going through. And these are stories that came to me from my immediate family and my church family, because they didn't know if I was going to make it. So that's when I think about the most impactful is how they were impacted. Because I slept for a week. It was the best sleep I ever had. I knew nothing about what was going on until I woke up and started to realize what was happening.
Jen, what's your perspective?
This is the first time I've cried in a long time. It's very emotional. It brings back a lot of memories of, talking with families and, just trying to explain what we were doing for their family member and just apologizing and grieving with them and, that they couldn't be there and that we were trying to protect them and trying to protect ourselves and explain what we did know at that time, because everything was changing. When Yolanda was sick, that was that was still the beginning of it. And we didn't know what we were facing. Every time Dr. Fauci got on the news, it was something different. Our infectious disease head, Dr. Kim Schreiner, who was very involved with Pasadena Health Department and was kind of our California guru. She's our West Coast Dr. Fauci. She didn't know either. And we just kept looking at the research and lack of research and what was done and, trying to do the very best we could. We would FaceTime with families, and that was our only communication with families. And families would be on the other side of the phone and we're in the room, in our spacesuits, so to speak, trying to protect ourselves and, crying and trying to explain. And the families are crying and asking questions and they don't understand and we don't understand. And we're just trying to do the very best that we could. It was heart-wrenching. I don't think I'll ever be over that, listening to families grieve and they can't be with their families. Families are so important. I mean, that's, what you have. So it's very hard to hear it.
Thank you, Jen. And we know that you've done a lot with families. This is a good thing for us to hear. How about one of our students? Let's get you folks to weigh in on that.
I think for me, one of the most impactful experiences, I worked as a CNA a lot of the times at my hospital, and I would be assigned upwards of 10, 11 patients to be responsible for. And when we had patients that were passing, one of our responsibilities was to facilitate the Zoom calls with the family so that the family can say goodbye. And it was an honor to be able to be in the room and sitting with them physically. But we did have to listen to families say goodbye and they weren't able to be there. So we, as the nursing faculty, we were able to step into that role and be that family when they couldn't be there.
Mm-hmm. So thank you. Brenda, how about weighing in on identifying a faith or a spiritual concept that was grounding during this time? and what you have found resonating in the life of our healthcare team.
I think the scripture that is the focus of this conference is very appropriate to what we were experiencing in the hospital. Be strong and courageous. Do not be afraid. Do not be discouraged, for the Lord God is with you. I think we called upon that constantly because we felt so out of control. We had to, as you heard, courageous. It took courage to come to work. So that scripture was very grounding for us. I know in my own life, when I came in as a chaplain, I called upon my centering. I know that part of my job is to bring calm to patients and their families and staff. So amongst all the anxiety, I would call upon my own faith, my call to my work, and why I do this work, and it would center me. And then I'd go to work and everything, I'd do my job, and I feel like I'm doing okay. And I'd get home and then I'd feel this heavy burden on my chest. And I would just feel the weight. And I realized when you work in that environment, you absorb the anxiety that's in the staff, it's in the walls, it's in the people. So I think calling upon our faith that grounds us, I had so many conversations. The staff would call and say, can you come up and bless this room? We've had so many deaths in this room. We don't want to put another patient in there until we have a blessing. So we would go up, chaplains, and bless the room, call upon God's presence of healing to be in there and on the staff. The nurses needed that symbolism. They needed to know that that the death was honored, that they had been experiencing in that room, and that we could call upon healing and good energy to be there for the next patient. So faith was very strong. Even people who aren't in an established faith tradition, prayer was constant for most everybody to get through the day, to know what to say to that family. There was a lot of stress and a lot of dependence on the commitment we have as nurses, the commitment we have as chaplains to give us the strength to walk in each day and the courage.
Thank you so much. How about, would someone else like to speak into a faith or a spiritual concept that kind of moored you through this time?
Yes, I'd love to speak. During this time of COVID, it was very heavy, and I understand what Brenda was saying when we would go home and all of a sudden you think you're okay, but in the heat of the moment, everything just falls into you. And as a student, we have so many other responsibilities outside the hospital with our education as well and keeping up with that. And I feel that in order to help relieve the heartache we would feel for the love we had for our patients during those hard times was really praying and taking a moment to reflect. Each day reflecting like what went well and what you did your best on. And I feel everything that nursing school had taught us about faith integration, about prayer, going through scripture, because it's so heavy. You can't do it alone. You definitely need God through it in order to like keep going back to the hospital.
Powerful words. So let's turn a little bit to looking at patient-centered care, which we hold very dear as a value in nursing. So what were some of the key elements that made patient-centered care successful during this time?
Well, as a patient, I can weigh in on some thoughts. I think when I went in, the care that was given to me and my family. I mean, my family felt that there was a definite effort to keep them informed, to help them through the process of making decisions, and so they felt that there was a strong network of nurses and doctors to help them, communicating with them. It was so important at that time. what I realized when I was in the hospital is, again, I was out for a week, so I didn't know what was going on with me while I was there. But when I woke up there and I was starting to get better, I realized a couple of things. One, nurses and the team that was working with me they had to go above and beyond their normal practice. And what I'm hearing, today, going out of their normal box, the first nurse I remember waking up to was John. He was in the ICU with me, and he woke me up. I was awake, the first thing I remember him saying to me is, "We're getting you ready because you're going to FaceTime your family. They want to see you." And I didn't know what he was doing with getting me ready. I was barely awake, and but he was. I know my gown was changing, my hair was being touched, and I didn't know. But when I FaceTimed my family, my daughter kind of chuckled and she said, "Mom, who made your chongo chongos?" And I said, I didn't know what she was talking about. When they were little, we used to make ponytails on their heads. We called them chongo chongos, and there were two little ponytails that stuck out. I didn't realize what she meant. And then when I went to my room and I finally got access to a mirror, I had these two ponytails coming out of my head like little water fountains. And I just chuckled and I laughed. And I said, "John made me these two ponytails, and here he is. He's a nurse trying to care for me. I'm sure he was never put through grooming school on how to do hair." And I just remember it. I held on to those rubber bands that he used in my hair, and I made a little bracelet with it. And I would often pray for him and the team, because I felt like they had just didn't know what they were dealing with, like Jennifer mentioned, and were going out of their way to care for me. The other thing I remember about John is, having been asleep for an entire week, when I woke up in ICU, I wanted to get out of the bed. I saw a chair and I wanted to sit in that chair. And I asked him, I said, "Can I sit in that chair?" And he said, "You want to sit in the chair?" And I said, "Yeah." And he said, "Do you think you can get up?" I said, "Well, if you help me." He said, so he tested my feet, my strength, and he helped me sit in the chair. And then he said, "You're the first person who's asked me to get out of the bed and sit in a chair. Just don't lose that spirit. When you're in bed, move your feet, move your arms, work to get out of bed." So that encouraged me. So when I went to my room, I did that. And the nurses that came to my room to care for me, I could see fear in their face. They didn't say anything. And one young nurse, I asked her, I said, "I bet you never expected to deal with something like this." And she said, "No, I have to be real honest. I cried my first day back the whole day because I was so scared." And just watching them having to dress and undress every time they came in is just, this was bigger than any of us. And I don't know, if you don't have faith, I don't know how anybody could get through something like this, not only with the nurses, but my family.
Thank you. Anyone else want to speak into what creates for effective, maybe Jen, what creates for effective teamwork during this time so that we can give that kind of patient care that we want to give?
Well, I would definitely, just before I touch on that, faith was, that's the only thing that got me through this whole entire thing. There's no way we did what we did without faith and without God, or a higher being, because we just didn't know. And the strength that we had to draw to overcome our fear and our anxiety, and to reinforce that we were doing the very best we could, or that we were making a difference or doing the right thing. I mean, there's just no way. I had to tell myself that God is using me in this situation, and I don't know why or how, but this is for him, and it's his calling, it's his direction. I mean, this is straight from him, and somewhere down the line, we're going to understand it. I still don't understand it. And I'm just patiently praying on it and waiting and knowing that God's going to reveal it somewhere down the line, or to my children, or to somebody. But teamwork, I think we just, once we overcame our fear or the unknown to some extent, or to the very best we could. We just realized that we had each other and that we had to support each other. And ultimately, I mean, we were all caregivers. And why did we become a nurse? We became a nurse or a healthcare provider to help people and to make a difference. And I mean, I know that this is, for me personally, God has called me to be a nurse. I know God has placed me where I am placed. I know He challenges me. He uses me every single day. And I know that. But others don't know that. Others don't have that faith. And so that was, I think, something I drew on, that God was using me and I was going to share God's love and God during this time. And I did. And whether people needed it or wanted it or not, but that was what got me through. And so we just dialed it in. We used each other. We cried together. We laughed together. We had a few glasses of wine together. I'm sorry. You know, we went on walks together. We just banded and knew that during this time, we were the experts. We were placed here for a reason, and we were going to do our very, very best to help everyone get better and heal. And those that weren't so fortunate, we prayed for them. We prayed for their families. We prayed, you know, we just focused in on the patients and what we are all called to do. And that's really what helped us through.
Wonderful. So what would you say, and some of you can speak into this as well, what was it like to have that work world of such intensity and fear and anxiety, and then have to leave it to go live a life outside, like have a family, like go to the grocery store, do laundry? How did you balance that piece out?
For me, I live with a couple roommates, but I call a lot. I often call my mom every day. I call my family every single day. And so it was hard at first to kind of separate the feelings that I would have at the workplace, and then later that night, my mother calling me, how was work? And I had to tell her, you know, it was a lot. I tried to be big because I don't want her to worry, but then I realized that, like, with all the heavy feelings I was having, I was able to take a second to step back, like mourn for what had happened, and then after I had mourned alone, and then I would go up to my family and say, it was rough, but I'm just blessed and grateful that you guys are still in my life and you guys are safe, but I'll be okay. Like, it's reassurance for them and reminding myself that, like, we have a support system outside of the hospital. We have our families, and it's hard, it's challenging because we're in COVID. So then at the same time, it's hard to really see all your family members. And so I feel like finding different ways to connect with them through call, video call, and people that you are living with, you know, like taking the time to step away and like remember that, like, we're doing our job because people that we're caring for also have the same life of being with a family or a friend that they live with at home. And yeah, it was that's what kept me going to the hospital, was remembering that they had their own families to come home to as well.
Anyone else want to speak into that?
I would like to say, during this COVID time, there was some differences I felt that we had to attend to in nursing in particular, that I was observant of. And yes, there was a lot of talking with families and trying to reassure them on the phone and helping them contact with their loved ones with different mediums. But when it was all said and done, the families could not be there. And I feel like the staff, the nursing staff, our chaplains, felt the burden of sitting in on behalf of the family with that patient, especially in the dying process. And it occurred to me that nurses have a way of having a healthy disconnection from the patient that keeps them able to move from patient to patient and from situation to situation. But in this case, nurses were being in place of the family and experiencing grief for that patient almost like a family member. And I think that in doing that, there was some trauma because we go from grief to grief to grief. So we're taking on grief that is not ours. It's their families, but we've become part of their family. So the grief that we feel as caregivers is cumulative, which to me, when you step back, you're taking that home. And it causes, I think, some post-stress, some PTSD, where the trauma of that and carrying that burden takes time to work through. And I think that's going to be the fallout of this in the healthcare, is that as we get past some of this intensity, we're going to find that we're extra tired, we're depressed. You know, we thought we would just bounce right back and there'd be joy and happiness, but there's a weariness that comes out of that, which comes from that stress and the trauma that we've experienced. I also think there's some moral injury that has taken place in this trauma, where I think of the nurses who were working early on without enough PPE and without enough staff, and they felt like maybe it wasn't safe and they were working in an unsafe environment and working outside of their practice values. And I think that caused some moral injury. So all of that to me is what we have ahead of us as we move into trying to make sense of what's happened. What have we learned from this? How do we take care of ourselves and each other and bring our faith into play in bringing God's love and support to ourselves, taking care of ourselves. We're helpers. We don't need help, but we are going to need help, and we're going to need each other to help us get the help that we need to move forward and to learn from this.
Thank you, Brenda. Yolanda, can you speak into what it was like to be discharged and discharged, what kind of support you had, what your perspective was on that whole experience?
When I was very fortunate. Like Jennifer said, you know, the whole thing on faith and being well supported. I'm very fortunate to have my immediate family, my church family, and my work family. So leaving the hospital, once I remember when I was talking to a doctor and I asked, he came in and he said, you know, you've really been through quite an ordeal. I'm amazed to see how well you are doing. And I said, you know, I'll never underestimate the care that I got at the hospital, the work and the skills of the doctors and the nurses. But I had an entire team of praying warriors praying for me. And I really believe that between the medical care and the faith and the people walking alongside me and my family made a difference in my recovery, because I jumped back pretty quickly. I was able to go home. You know, maybe it was Redesomare, maybe I don't know what, but I'll never underestimate anything that happened during that time. So coming home, we were well cared for, you know, family, friends, and but one of the things that I realized coming out, I had great care, feeling better, but afterwards, the aftercare, didn't know where to go or what exactly to ask for. I didn't know if what I was still feeling was because of COVID or because I had gone just through a traumatic, anybody who goes through a surgery or some kind of traumatic care. I was losing hair. I was, and fatigue and all these things going on. And if there's anything is just understanding what should I be looking for? Because this is all new. Even the doctor, when I spoke to him and I said in the hospital, will I get this again now that I've had it? Will I get it again? And he wasn't sure. And he was real honest about that. He said, you know, this is all new. It might be like the flu. It might be something you get it once and then you could get it again next year. So it's just understanding more about what should we be looking for. I think one of the most discouraging things for me was I was assigned an infectious disease doctor, and I was, you know, trying to get an appointment with that individual was difficult. I went out of my network, so I had to get all the records from the hospital before they'd see me or schedule an appointment. But then the response was, but why do I need to see you? You're better. You're okay now. You know, and I was thinking, well, maybe to see what the after effects are. You know, so I that was probably my one thing in terms of coming out of this is what should the aftercare look like? I'm still I'm very fortunate. I feel better. I'm doing better. I'm back to work, but I still struggle with fatigue and a little bit of brain fog. Mm-hmm. But I don't know if it's age. You know, I don't know if it's my age or if it's just stress at work or what is it. So that's some of the some of the things that I would be focused on.
So what other takeaways do you think are important for us to communicate to our communities, to people who care for us, to our families, as we're getting ready to close?
You know, I saw a question come up in the chat that said, what were some logical ideas? And I think what Brenda shared is really important in terms of the healthcare, but I think it's important too, through this process. And what I realized when I was in the hospital is that every patient is different. And I know during this pandemic, there is no way you could have done more than what you did. But I know a nurse came in and made comments about how well I was recovering. And I asked how many people were on the same floor. And I think it's understanding that every patient is different and just understanding what motivates them. What are their fears and how could that impact how you care for them or how you help them move forward is something to think about as we're still dealing with some of the after effect of this.
Remember the ponytails. How about you, Jen? Can you speak into that, please?
Yolanda, it's such an honor to listen to you and be a part of this panel with you. I've been most excited about speaking with you just because you were one of our patients, and it's a real, I mean, it's God that we're together doing this. But yeah, I mean, you know, we in critical care, we did the war treatment, so to speak. You know, we just did when the patients were most critical. But healthcare is a continuum, and like you said, treating everybody individual, because everyone is different. Everyone brings something different to the party. I always tell my students that, what does your patient bring to the party? What's their history? What's their culture? What's their beliefs? Who are they? And that's our job, to get to know our patients individually and know where they come from and try to treat them on an individual basis. Everybody's different. And to give you the best care that we can, incorporating all those things. So yeah, I mean, we only see that part, but there's so much more after. And how is the patient trying to re-engage into the community, into their life, going back to their family? How is their family dealing? Their family has been traumatized as well as you, or as a patient. So it is, we really need to look at the whole continuum of care and how to get through this so that we heal as a community, as a nation, as people.
Great.
I don't think I answered your question. Sorry. Okay.
In terms of moving forward, what's the takeaway? Brooke, why don't you be our last person and speak into what do you think is the takeaway for nursing students looking forward that you might integrate into your practice as a new nurse?
For me personally, one of the biggest takeaways that I experienced during my whole time in the hospital was just reorienting myself and reminding myself that each room that I walk into, that's a person. There's someone's daughter or son, there's someone's wife or husband, and they have family that care for them, and they need to be treated as a person, not just another patient or another number. And seeing them as a person, meeting them where they're at, like Professor Pei said, each person brings something different. You can learn something from each and every patient that you encounter. And just like a reminder for students that like take the opportunities that you get in the hospital to learn as much as you can while you're a student and while you have that time to sit and talk with the patients, because just especially during this time when they didn't have family, people were desperate. The patients were desperate to talk to anyone. They felt alone. They were isolated in rooms. People would come in and out quickly because they didn't want to be exposed for too long. So it's like taking the time and sitting and getting to know each and every patient that you have, because it's an opportunity to learn something about them and something about yourself and to better your care for each patient that you encounter.
Beautiful. Okay, so I think that wraps it up. Thank you so much for taking us there, both on both sides of the bed rail, if you will, right? Are there any questions that have been raised or that people would like us to address? So while we're waiting, let me just ask one more question here. Brenda, what words of wisdom would you give teams while we're waiting for questions to come in? Would you give teams, would you give leadership in how to best care for their teams and as they care for patients?
I think that's one of the things we're going to take forward is that we were scrambling in our institution, and I was talking to other chaplains across the country, is how do you support the staff in this crisis mode? And we became very clear that if you don't support your staff in meaningful ways, it will affect patient care. So more than ever, we realize that you need to have a staff that feels cared for and supported and understood in what they're going through. That was one of the complaints I felt from staff, is that they didn't feel like the administration understood the stress that they were under. So I think going forward, we're going to look back and say, what did we learn about staff support and how to do that better? Because we were all scrambling. And staff is like our patients; they're all unique and different meanings. So it's a big thing to try to figure out how to support staff individually and as a group. So I think there's going to be a lot of research on that. I know chaplains are working on that because that's part of what we feel is our responsibility is staff support. So I know we're going to be having lots of seminars and education opportunities in the future to look at that, because it's so directly related to patient care. So I think that's one takeaway that we'll see.
Any questions come in?
I see that we do have a question. Bridget, do you want to share that one from Juan?
Sure. I have a question regarding, and it's still kind of early. We're still in the pandemic, but have things already improved from management regarding staff support from your perspective?
I do think so. I think some staff administrations were wonderful. They put on scrubs, they got out on the floor, and they demonstrated that they understood the stress the staff was under, and that was very meaningful. There's other hospitals where administration protected themselves and felt like they didn't need to be out on the floor. They needed to protect themselves so they can continue to do administration. And it was hard for the staff to feel the support of administration, even though a lot of stuff was going on, when they didn't see them out on the floor with them. So I think that's one takeaway that that administrators are going to have to deal with, and many of you are administrators. So the power of getting out on the floor and demonstrating your understanding of what your staff is going through, very helpful.
Thank you. I have another question. What recommendations do you have for nursing faculty as we work and we learn to support students during this time, and maybe some of the students and maybe the faculty member can answer?
Okay, so let's hear it from one of the students. What do you think we could do to better support you as you were exposed and lived this event?
I think to better prepare us would be allowing us to remind ourselves the importance of self-care. I think we are always taught that, but to actually live through the pandemic and being in the critical care setting, I feel like a lot of students that take on the role of nursing school, like they tend to get really passionate about being with their patients, and they forget that you gotta take care of yourself at the end of the day as well. And I think that was what better prepare us, because I don't think anything could fully prepare us for the emotions that came, that the building of emotions that was coming from all these patients that were either passing away or were very critically ill. But I think the best was just providing emotional support and reminding us that we weren't alone throughout the whole process. And I felt that in our staff.
Jen, can you speak into that, please?
I think as a professor / bedside nurse, I really try to focus with my students, and I try to make this a point every semester, and speak into self-care as a nurse in general, without a pandemic, and just how much as a nurse you sacrifice, because we are giving, we care for others. And I think that's just in us, whether we want to admit it or not. We care for everybody else. You go to work when you're sick. Well, we don't do that anymore, but I mean, you do all those things and you sacrifice. And so self-care is so important. During this time, I really spoke into infection prevention, maintaining safety as a caregiver. How do we protect ourselves? Infection, and then also, of course, trying to understand why we do things and what we're doing and the reason. So I felt like as an instructor, I really tried to set time apart with my students and explain that and show that. And then also, we do sacrifice, but we also have to make sure we take care of ourselves.
So thank you. I think the time is done, correct? I can't tell if there's another question, but thank you. On behalf of everyone, thank you from the depths of our hearts for being there, and most certainly for sharing of those experiences that not only resonated, but they drudged up some more feeling, right? That we have only begun to be able to articulate about. So thank you, and thank you for being willing to be on this panel and taking us to this point.
Yes, thank you, panelists. It really helps make it real, Yolanda, for being willing to share your experience as a patient and a survivor for this. And Rochelle and Brooke, you are rock stars. And when I have to go in the hospital, I just hope I have an APU, a grad nurse that's going to be caring for me then. Thank you both so much. Thank you all for this. And with that, we will now transition to our next panel presentation. These panels are helping us have a little better sense for what the front line has looked like from the bedside to the public health and perspective. And as we said before, this pandemic is intensely individual and intensely public all at the same time. So Dr. Teresa Dodd-Butera and Dr. Marissa Brash, faculty in the School of Nursing, will be guiding us through this portion of our morning.
Good morning. Thank you for having us, and really humbled to follow those great presentations. So our presentation is going to be on public health and the pandemic, conversations and lessons learned. So the objectives are going to be at the completion of this module. You're going to be able to describe the core functions of public health and the application to the COVID-19 pandemic, to identify the contact tracing process in public health as utilized in the pandemic, and to discuss opportunities for interprofessional collaboration on prevention and health promotion during pandemics and public health crises. So just to give you an overview about our presentation and our presenters. My name is Dr. Teresa Dodd-Butera. I'm a professor and in both the doctoral programs and public health. I'll be talking and giving an overview of the core functions of public health. Dr. Marisha Brash is the chair of the public health department in the School of Nursing, and she'll describe the assessment and monitoring health. She did a lot of work connecting with the community. We're going to have two of our students, Shana Simona, who's an MPH candidate, will discuss contact tracing and her experience addressing assurance. And Joe Eggleston is one of our Randall Lewis Health Policy Fellows, and he's going to be talking about his experiences with emergency preparedness in the pandemic. And then we're going to end with the idea of some hopefulness about approaches with prevention and health promotion. I am adding this slide because I want nurses to remember public health isn't something separate from them. They are integral to public health. This is a pyramid of what the CDC counts as the public health system. So of course it includes federal agencies, state, tribal, local, territorial health departments, government agencies, even beyond public health. But you'll notice clinical care delivery systems are integral to that pyramid and considered part of the public health system, which is what we've heard descriptions of nurses participating in very heroically in these past months and over the past year. But it also includes community-based organizations, faith-based groups, educational institutions such as APU and just the public school systems, private industries, private nonprofit associations, and different media outlets where we can communicate and disseminate information. So the care you've given is part of public health. One of the things that we decided to, in our approach to talking about public health, is a framework that looks at assessment, assurance, policy development, and central to the core function is equity. So I really love this diagram because it really looks at all of these core functions as the whole. You need all of these things to actually provide public health. And so we talked about the different agencies that are part of that system, but also the idea of assessing and monitoring public health. And of course, Dr. Brash will talk with us. Investigating, diagnosing, and addressing health hazards and root causes. We have contact tracing. The idea of communicating effectively to inform and educate. We had a lot of confusion over this past year as the research was changing. And so it's important that we're part of that effective communication, that we strengthen partnerships, and we'll talk about how we did that, that we create and champion and implement policies and plans. All of you were part of what that response was and what policies were enacted, how we utilized legal and regulatory actions, and then of course, assurance. And so central to that is building and maintaining a strong organizational infrastructure for public health, such as hospitals and schools of public health, but also that we're building a diverse and skilled workforce. And so I think we wanted to illustrate how APU worked with other agencies with their students so that they were able to get firsthand experience, but also it was part of their training, that idea of there will be those who know what to do when things come to visit us again, as they will. We always need a trained workforce. And so central also to all of these things is that idea of equity. This has been quite a year for public health and lots of other arenas. And so that idea of health equity and us being promoters of that when we enact public health, when we function as individuals, is going to be central to what we're talking about today. And so I'm going to turn it over to Dr. Brash, and I want you to note that we have put our emails, both Dr. Brash and I, if you want to get in touch with us, after the presentation. So I'm going to turn it over to Dr. Brash, and she's going to have a presentation and a conversation to share.
Thank you for that introduction, Dr. Dabutera. So basically, what I want to discuss with you is my role in the assessment and the assurance components of this public health pandemic. And so part of the assessment component really was being able to monitor the public health policies, legislation, and communication. And that was essentially a very difficult component in the very beginning of the pandemic, because at APU, we have 5 different campuses in regional counties that we serve. And so that meant monitoring all of the communication, policies, legislation, health officer orders coming out of Los Angeles, Orange County, San Diego, Riverside, San Bernardino, as well as for the state of California, and then within the United States government, as well as from the CDC and the WHO. That was really important because each of these entities provided communication in a different format and in a different frequency as well. So being able to find, daily telebriefings, press conferences, updates, emails, Twitters, et cetera, for all of these different entities was an important component of that assessment phase of being able to identify how to find the most up-to-date, relevant, and reliable information. And so that was an important component in terms of monitoring the data and communication that was being put forth for all of these areas. And then in the role of assurance, the really important focus for us was on building the public health workforce. And we did that, ideally through our public health students. So at APU in the School of Nursing, we have a Master of Public Health program. And in this Master of Public Health program, we have these public health students, and part of their expectation is that they will complete a field practicum as part of their graduation requirements. And so the field practicum we focus on for a lot of students really changed during the pandemic. From some of the community health and international health opportunities we usually focus on, we really pivoted towards being essential in this public health workforce. And so 2 of the major opportunities that we had were working directly with the LA County Department of Public Health, and specifically focusing on 2 factors. So in the beginning of the pandemic, the first thing we really focused on was contact tracing, when that was a really big need in the LA County sector. LA County specifically said that they needed public health students to kind of serve these contact tracing roles, as we had case counts that were daily above 8,000 people a day. And so each of those contacts needed to have somebody reach out to them and then be able to reach out to all of their contacts as well. And so that became a really big problem for LA County. And so they relied on students. And so we worked with the School of Nursing and actually with the nursing students. Amy Pizantian was one of our key contributors in creating this contact tracing internship that our public health students were able to work in. And so basically we had teams of 4 to 5 nursing students, and then who were contact tracing. And then we had the MPH students who were serving as team leads, as well as contact tracers themselves. And they were hired on directly through LA County Department of Public Health. So they were actually trained, they were given LA email addresses, and they were actually considered part of that LA County workforce. And so we had that opportunity beginning as early as summer 2020. So we had students who actually began that internship really at the big pandemic. So in May of this year, we had students working contact tracers for the LA County Department of Health. Now, as we get to this point now where we used to kind of wind down in the number of cases out, so LA is now having about 500 a day. So there's not as much need for students to step in roles, but what the LA County said is that they need students working in their vaccinations. And so we're pivoting to now actually having student work in the vaccine months, those point of distributioners for vaccination. So once again, we're partnered with nursing. So public health students don't give vaccines themselves. We were nursing teams, and so we work with Prada, and she actually organizes this opportunity at the San Gabriel Health Center, and we have students who are nurses who are providing the vaccines, but then we have public health students working alongside them who do the administration and management of those pods, and then health education as well. And so those are opportunities that are beginning right now and going straight through into the summer, so that we have the opportunity to have our public health students on the front lines. And we're really excited about it because we've been so fortunate to have these interdisciplinary teams where it really is teams of our nurses and our students working together in these really amazing opportunities. And so to discuss this in more depth, I actually am bringing in one of our MPH students, and I'm going to have her introduce herself. But it's Shayna Simona, and she is going to be joining us to have a conversation with me a little bit about what it was like and what the experience was, and what kind of doors and opportunities that opened in that public health workforce. So we can discuss that idea of assurance in a little bit more depth, and talk about what the experience was working for the LA Department of Public Health. And so she was one of our first students in the summer of 2020 who completed her internship at LA County. So I'd like to kind of bring her into this conversation now. And Shayna, I'd like it if you could just introduce yourself, let us know a little bit about you, and if you could tell us a little bit about the project and population that you were working on during your field practicum internship.
Thank you, Dr. Brash. Hi, everyone. So I began contact tracing for the Los Angeles County Department of Public Health, DPH, from July to August 2020 full-time. And working as a contact tracer, it gave me real life experience within public health, specifically community health and epidemiology. I provided services to my community in a time of need when COVID transmission was high. Contact tracing for COVID-19 was a newer program at that time, and I was able to learn alongside other LA County leaders as they were learning the process as well. I called people who tested positive for COVID-19, close contacts, and conducted final interviews. The guidance was constantly changing, scripts were often revised, trust in public health varied by caller, and new lessons were learned each day. Flexibility and self-care was an essential part of managing the daily responsibilities as a contact tracer. Throughout my contact tracing experience, I've worked with culturally diverse populations and improved my communication skills that have helped me in more recent job experiences.
So that being said, how would you say that your experiences in this internship as a contact tracer ultimately affected your health practice?
Yeah, contact tracing was not only an invaluable experience, but also led me to my recent job opportunities. In September of 2020, I worked as a graduate student assistant for the School at Nursing here at APU. Specifically a part of the clinical placement team. I helped process compliance forms from the School of Nursing before nursing students could begin their field practicum. Then in November, I was hired as a pandemic coordinator for the Downtown Women's Center that serves women experiencing homelessness in the Skid Row community. The most impactful deciding factor for my employment was my contact tracing experience. Throughout my employment at Downtown Women's Center, I have used my contact tracing experience to provide guidance to staff for quarantine and isolation, as well as effectively working with the Department of Public Health when the workplace had COVID-19 outbreaks. My experiences from contact tracing to work as a pandemic coordinator has also led me to pursue a PhD. In fall 2021, I will begin a PhD program in environmental health sciences at the University of California in Irvine. My experiences from contact tracing had a strong impact for my decision to go into the field of environmental epidemiological research so that I can continue to advocate for equity and care in underserved communities.
So I know you've already given us a little bit of the information, but I'd love to hear a little bit more specifically about how this opportunity to serve as a contact tracer really connected to the issues that you saw resulting in outcomes related to the COVID-19 pandemic.
Well, during this pandemic, we have learned that information keeps changing and we need to be understanding and flexible. It also is important to be able to effectively communicate new information to the target audience. As a contact tracer, I needed to describe quarantine or isolation information with a culturally sensitive perspective. As a graduate student assistant, part of my responsibility was to do research and provide new guidance on information like personal protective equipment to some of my team members. And as a pandemic coordinator, I needed to do all that I mentioned while recommending policy updates as new guidance comes out from LA County. Each of my experiences have taught me that in order to overcome the challenges of the pandemic requires team effort. The takeaway point that I learned from all of this is that we as a community are strong. And if we work together through strong communication and have an understanding that information about COVID-19 is constantly changing, we will overcome all obstacles as we have continuously shown. Many of the processes regarding COVID-19 were brand new for these organizations as the disease is new, but with a group effort, understanding, and patience, we created effective systems to keep the community safe.
Well, thank you so much for joining us today, Shayna. I think that this was a real helpful description from somebody who really did work as a public health student in the beginning of the pandemic, and really seeing that assurance process, understanding a little bit more about how to create these public health infrastructures, because we know that that's going to be such an important component going forward, is that we are going to need to invest as a community in our public health workforce. And so the place we can really do that is through our students, who are the next generation of public health practitioners. And we can really see, especially here, how the public health students work alongside the nursing students in the nursing department so effectively in these interdisciplinary teams. So it's been so helpful to hear your perspective and your experiences as a student in the front line of this COVID-19 pandemic. So thank you so much for being here. I'm going to go ahead and turn it over to Dr. Dabutera. Thanks.
Thank you both so much. That was really informative. And of course, we want to thank Dr. Brash for her work throughout this. She's been a lot of our eyes and ears and keeping us posted on what's going on. And Shayna, that was really great to hear about your experience, and we thank you for your service too. Now we'd like to welcome Joe Eggleston. He's going to talk about the policy development portion on this public health panel. He is an MPH student and one of our Randall Lewis Health Policy Fellows. I want to give you a little background on the Randall Lewis Health Policy Fellowship. This is a competitive fellowship that is across Southern California, developed by Mr. Randall Lewis. He very generously partners with universities. There are students from multiple disciplines who work together on various public health issues to look at what policies are needed to be developed now and how they can contribute in the future. And Joe was just one of our really stellar fellows. So Joe, go ahead and introduce yourself. Tell us a little bit about yourself and the project and the population that you worked on in your fellowship.
Sure. So thank you for having me. As Dr. Dabutera mentioned, my name is Joe Eggleston. I'm currently an MPH student. I'm also the Associate Vice President for Auxiliary Operations at Southern California University Health Sciences. And I was really humbled and honored to be able to participate in the Randall Lewis Health Policy Fellowship. The site specifically that we worked on was the Carolyn E. Wiley Center located in Riverside, and they serve about 3,500 clients each year, and they focus more specifically on individuals with special healthcare needs, including a large population of those with autism spectrum disorder.
Okay, and your emergency plan, talk about how you worked with them, specifically designing a couple of things. I think you did a really great job, and what your objectives were with that.
Sure. So when we first came in, we conducted a full SWOT analysis to determine the strengths, weaknesses, opportunities, and threats that the Wiley Center had. And we wanted to focus on helping their policy and using them really as a template. So we didn't want to use the Wiley Center as a one-off. We had a lot of collaboration with their CEO and a lot of collaboration with the special healthcare needs community, and they wanted to see an example of how there could be disaster preparedness that was tailored to this community. And so the health policies that we developed, a lot of them were from scratch. They just didn't exist previously. But we developed a full emergency management and operations plan for the Wiley Center that would allow them to basically plug and play with first responders. So we used what's called the incident command structure. It's widely utilized disaster triage system. And so we use that to build the Wiley Center's policies and procedures. And we did it in such a way where we built what's called functional annexes that can be superimposed over certain disasters, but still be relevant. So kind of a Swiss Army type policy where it can be applied to multiple different disasters. But yeah, a lot of it was from scratch, and a lot of it was informed on the ground from information that we were getting about the pandemic. We were learning on the ground as we're writing this policy what a pandemic policy looks like. So when we first started writing the policy, it wasn't pandemic driven. It was driven, earthquakes, and wildfires, and active shooters, and these were the disasters that we were seeing at the tail end of 2019 going into 2020. And then obviously, March of 2020, we had the pandemic, but we were kind of doing a multi-hazard approach to address all of these issues. And I feel confident that the policies that we created serve as good templates for other similar institutions.
Mm-hmm. Yeah, I think that you did a great job with that. I think also connecting the pandemic, and one of the things we talk about is equity. And so specifically to this population, when we looked at families with children with special health care needs, like you said, we had originally started, and we actually did talk to them about disease outbreaks long before the pandemic. We were focusing on wildfires and, as you said, earthquakes and other things. We connected it with the pandemic related to, I think, evacuation and both sheltering in place. But you uncovered some things where you could advocate for families. So could you describe some of those issues related to health equity that you learned about during your time in fellowship?
Yeah, definitely. Thanks for bringing it up. It was one of the first things that we came across in our research of how to approach creating evacuation protocols and shelter protocols for individuals with disabilities. There wasn't a lot of research out there for how to do this, and the research that we had, specifically one in particular, came from the Governor's Office of Emergency Management that said for California shelters, all individuals with disabilities should be treated the same as members of the general population. That sounds absolutely fantastic from an inclusivity and equality standpoint. But when we're talking about health equity, I hope you can see the problem right away. So these individuals with special healthcare needs, very likely are going to have different disaster related needs than the general population. They may have sensory sensitivities or medications, et cetera. And you're going to need to plan for that ahead of time. You can't just accept everybody at once. And the work can be done. You can plan ahead of time for these populations. And that was really the whole point, was, you know, you could do the work and plan ahead for this. To Dr. Dabutera's point of how we incorporated planning for the wildfires and planning for the shelter with the pandemic, what we had already done is the Wiley Center could easily hold 150 or so people, but we had specifically built the emergency shelter plan to only house 50. Our distancing was somewhere around 6 to 8 feet, even before we knew about the pandemic social distancing restrictions. We did that to provide people enough sensitivity space, but we also provided individual rooms that families could go to if they needed to be deprived of certain sensory triggers, and they could have some alone time. We additionally had stocked the supply center with N95 masks in preparation for a potential wildfire. And we were able to say, well, those resources could be reallocated for a pandemic protocol as well. So that kind of shows you how these resources were kind of retooled, and we kind of rearrange how we have certain resources to be able to fit certain disasters, in this case, the pandemic. Did that help address the question?
Yes, thank you so much. Really, it was just great to work with you on this fellowship, and I thank you very much for coming. I think when Joe and I were talking and preparing for this, we talked about the lessons learned from this in terms of, I guess what we're seeing, it struck me what one of the nurses said before, and what Joe and I have been talking about, that there's equality where you're giving everybody the same thing, but then there's equity. Each patient is different, each family is different. Equity is about getting people what they need. And this became very, very clear in the pandemic, when we had just multiple issues occurring. We had to worry about that idea of, what do we do with evacuation of wildfires? What do we do about sheltering in place in the midst of this pandemic? So thank you so much, Joe, for joining us and sharing your experiences and representing APU so well in the fellowship. So I want to, I guess, talk about where we were as a review. Here we go. So just as a review, that we're looking at that public health framework that nurses and hospitals are integral to. They are part of this, that looks at assessment and assurance and policy development, and that you're part of providing these, what are considered 10 essential services, where we're assessing and monitoring population health, investigating, diagnosing, and addressing health hazards and root causes. And then, in fact, addressing prevention methods, communicating effectively, that nurses and all public health professionals are clear on what is the latest evidence and how we communicate that, to strengthen, support, and mobilize communities and partnerships, that we create, champion, and implement policies, plans, and laws that are equitable and effective and efficient, that we utilize legal and regulatory actions, enabling equitable access for people, building a diverse and skilled workforce, improving and innovating through evaluation, research, and quality improvement, and building and maintaining strong organizational infrastructures for public health. And so going forward, I put together a little sort of montage looking at kind of where we came from, where we're going. And one of the things that was probably, I don't know, probably one of the most things that caused confusion, let's say, were masks. And so initially some of the recommendations were, well, we don't want the public maybe taking up some of the N95 masks because we need those for the most at risk in the hospital. Should we wear masks? Shouldn't we? And in fact, There's some evidence. I have one reference, but believe me, if you email Dr. Brash or I, we have a wealth of references on all the public health prevention methods where we're looking at masks. And so if you look at where we're going and where the recommendations are, in fact, continuing with masks, social distancing, and actually ventilation and hand washing is still what is considered that has been incredibly effective in terms of stopping the spread. And public health addresses, multiple things. I have up here some wordles we look at the environment, we look at infectious diseases, we look at public health in many different ways in terms of acute and chronic exposures and programs. But I think it's really important to remember that there's multiple public health challenges going on simultaneously, that nurses are taking care of people, that we need to encourage continuing health promotion, even during a pandemic, that someone is actually still taking note of their cardiac or other issues, and that we are prepared for emergencies, multiple types, that we are working with public health departments, and that we are keeping abreast of the science. And so I wanted to just give some COVID statistics to remind people of some of the sobering statistics that we've been faced with over the past year. In the USA, we've had 32 million in terms of actual cases. We've had 582,000, and this is of course fluid, they update them periodically. In terms of the vaccinations, we've had 86 million people, or 26.3% of the US population is fully vaccinated. And we have 133 million reported, or over 40% of the population that have received one dose. Worldwide, there have been 141 million cases and 3 million deaths from COVID. And so some of the measures that we're looking at in terms of vaccines, and we are actually going to have a presentation on vaccines at a later date that goes a little bit more into this. But when we look at this, Pfizer, Moderna, and we had Johnson & Johnson that had federal emergency authorization. Pfizer and Moderna, of course, being the mRNA types that kind of introduce sort of teaching your cells how to create the protein. And then the Johnson & Johnson was the vector version, where you introduce a modified version of a different virus. But looking at where we are, Pfizer reports 95% effectiveness at preventing COVID-19 virus with symptoms, and you have to take that in 2 doses, as we know. Moderna reports 94% effectiveness at preventing the COVID-19 virus with symptoms, again, 2 doses. And Johnson & Johnson, which is currently on pause, is reporting 66% effectiveness at preventing the COVID-19 virus with symptoms. And of course, these statistics are a little different when you look at specific populations for patients who have diabetes, or people living with diabetes and other types of conditions that put them at risk. And so the reason I bring this up is that idea of prevention and health promotion. And so when we think of in public health, we think of primary and secondary and tertiary prevention. And so preventing, like wearing masks and social distancing and washing your hands before you ever get it, is of course, ideally what we'd like to see. Primary, when we think of things like secondary, let's say you have a person who already has it, and then they can put them in quarantine, certain treatments to prevent worsening symptoms, and things probably nurses are familiar with when we talk about tertiary prevention, things like someone who's already had some cardiac event and you want them to go to cardiac rehab. So it may be that we are heard from patients who said that they might be having some after effects. And so we may be developing some protocols as the evidence comes more about from as the patients survive as to what would be the best thing in terms of tertiary prevention from any of the long hauling symptoms of COVID. And so right now we're at COVID-19 cases at about 67,000 per day over the past week. As we relax restrictions, there is concern about more infectious virus variants, and as people gather again. Vaccinations do ease the pandemic, but we still need those preventive safety protocols. Of course, we don't want anybody to get the disease. And overall, the number of new COVID cases in the last week fell 0.4% nationwide. And it's the first time in 5 weeks that case numbers have decreased. But that is overall. There are actually some states that are not in such good shape. And the number of deaths, which is good news, have dropped overall about 3%. And so hospitalizations now stand at 36,600, about 2,000 fewer than a week ago. So I want to end on something hopeful and just to show how important everybody's role is in this. The first US vaccine was given to Sandra Lindsay, who was a nurse at Queen's Hospital. She volunteered to be the first person in December 2020 because she said she wanted to inspire people who look like me to go ahead and get the vaccination, to get treatment and to tackle this. And so I want to end on hopefully saying that we want to continue to inspire others. I have been inspired by this conference and hearing everyone, and I wish everybody good health, and with God's help, you know, we'll go forward. Thank you.
Okay, wonderful. Thank you, Teresa and Marissa and Joe and Shana for helping us better understand the breadth and width of this pandemic, what's happening and what still needs to be done moving forward. Next, we are blessed to have Dr. Renee Poza, our Senior Associate Dean. We've asked her to provide a summary of this day and share some of her own personal thoughts and reflections. And then following that, we will have a benediction by one of our School of Nursing chaplains, Michael Morales, Chaplain Morales. And then we'll have a few final words of instruction as we finish this session of our webinar. So please, Dr. Poza.
Thank you, Dr. Wood. Thank you for tasking me with the difficult job of doing the summary. This was an excellent conference, and thank you so much to each of our excellent presenters and their wonderful presentations. It's good to reflect back on this difficult year, and also looking forward to the future and the lessons learned that we've had. Thank you so much to Dr. Brent Wood for leading the Research Symposium and the entire Research Symposium committee, who've been working tirelessly on the efforts to put a virtual conference together so we can be with each other virtually and learn about others' work and research. Thank you especially to the School of Nursing staff, Jeff and Jasmine, and our IMT support as they've put this conference together today. We couldn't have done it without them, so thank you so much. Hopefully when you see these people, please give them our deepest appreciation and thank you. And finally, I want to really commend the students that participated as part of our panel presentations today. It's not always so easy to get up in front of your colleagues and fellow students. You all did excellent jobs with your presentations, so thanks for your participation on the panels and for the work that you've done during the pandemic. So let me just do a little summary and then we'll get into a benediction with Chaplain Mo. So we started off the morning with the Provost giving us a welcome, and our dean, Dr. Lesh, she challenged us to think in the School of Nursing of providing dynamic learning environments and the development of knowledge to inform our practice. She reminded us of the importance of Florence Nightingale's work in data collection and interventions to improve patient outcomes. Ultimately, what many of us work on is how do we improve and provide safe care for the patients and families we serve, whether it's in nursing or in the public health area. Our first speakers were Dr. Lynch and Dr. Filizarro from England and Portugal, where they talked about the common experiences of nurses across the world and presented data from 9 countries in Europe, where they examined the lived experiences of nurses. And we heard from them as nurses have worked in these new roles, taken on new environments, the whole issue of PPE and donning and doffing, as well as the stigma and the fear that comes in caring for patients as nurses. They talked to us about the resilience dividend and reminded us of challenges in reorganization, in innovation, and new rules that we've engaged in over these past year. And I specifically want to highlight this theme that I think came out in several of the presentations around nurses become like family members, right? So we have providing the nursing care, but we're also being the caregivers when family members are not able to be present. And certainly the impact of telemedicine and telehealth on some of the work that we've done. Dr. Lynch reminded us that this gives nurses a voice. We became visible during this pandemic, and she discussed the nurses' capital. And finally concluded with a very poignant story about a new nurse who became overwhelmed and stepped away after 9 months. So for those of us that are working either with new grads as they're entering into our healthcare systems and infrastructure, as well as the nursing faculty that are participating, that gives us pause as how do we support students? How do we support new nurses that are entering to the field, as well as provide appropriate support for the established nursing staff? All important areas that we need to continue to work on and think of going forward. Our second speaker of the day was Dr. Kellogg from UMass Dartmouth. She spoke with us about the impact of the COVID-19 pandemic on nurses in the US. She provided a look at some interdisciplinary work with her colleagues in psychology, looking at research and stress in nursing, and talked to us about the prevalence and severity of secondary traumatic stress in nurses and how that stress then impacts the functional status of the nurse. Again, her theme of nurses being the family member and entering into a caregiving role came out in her work, as well as the impact of the required PPE we all learned to wear and the adjustments to our new normal routine. She described poignantly the impact of the patient's death and the helplessness nurses feel, and described exhaustion, the overwhelmingness, and the quantity of the work that was always there. And she demonstrates the importance of the systems and processes that are needed to support the mental health needs of our nurses. Excellent presentation. And then we moved into a panel presentation focused a little more on a local area and the impact and lived experiences, where we heard from a patient's perspective, a chaplain, a critical care nurse, and 2 of our nursing students who stepped into externships during the fall and winter surge here in the local Southern California area. We were reminded of the grounding of our faith and the importance of the grounding of our faith to be strong and courageous as we move forward through this, and the importance of prayer and reflection to keep us going and our own self-care as we continue to show up day after day to provide care and compassion to those we serve. Yolanda, the patient, said, this was bigger than any of us. I thought that was a great quote for us to take away. Jen said, God calls us to be a nurse, to live a life of service and dedication, to continue to show up to do our best, called to be difference makers. And Brenda reminds us the impact that this will have on nursing staff and patients and families with moral distress and the moral injury that we've all suffered. Therefore, again, reminding us of the mental health needs that will continue on, that we need to continue to do more research and provide interventions for this in our healthcare teams. And Yolanda said, what should aftercare look like for post-COVID infection? I think that's an important research question that many of you will hopefully engage with as we move forward into impact on neuro, cardiac, respiratory, fatigue, and the likes. And then certainly the students presented the challenges of being a nursing student during a pandemic. And I hope they will continue to tell the stories, both in presentations and in publications, as many of the nursing students here at APU have stepped into critical roles early before they thought they would be ready to do that, and often away from the guidance of faculty standing alongside them as they're navigating a stressed healthcare system and many challenges with patients and families that they were serving. I so commend our students for stepping into work in the pandemic. What an opportunity, but also a challenge. And finally, our final panel presentation, public health and the pandemic, really emphasizing, never before do we realize the importance of a public health workforce and the infrastructure needed in our policy area that will impact practice and the health of our nation as well as global. We had some great examples of interprofessional teams of students working in contact tracing. They worked in COVID testing sites and now are working in the vaccination clinics as we look to try and increase that number that Professor Dodd-Butera shared with us of close to 30% of our population has received vaccination. And we know we need to get that up to closer to 70 to 80% to achieve herd immunity. And finally, we heard about the Randall Lewis Health Policy Fellowship and the importance of planning for disaster management. And finally, Dr. Butera talked briefly with us around some of our social distancing procedures and vaccinations, and gave us a call to continue to challenge each other to move vaccination rates up so that we can achieve that. So just in closing and summary, I think we have lots of things that we learned today that we can take and move forward. We continue to find new questions as we search for that new knowledge. And I think there's been opportunities from what we've learned over this past year and a half that we will continue to define and explain and study with new interventions and new ways of doing things that we will move forward. Whether that's our workplace environments, many of you saw staffing ratios adjusted, how we did our charting became different. What are the lessons learned from that experience as we look back? Many of you, as we saw nurses get vaccinated, and the emotional experience that provided some relief. Many nurses, I don't know that they realized the fear that they were working under day by day. And so what is the impact of that? I think of our patients and their regaining of trust in many ways into the healthcare system. Are they willing to come back into our offices and clinics and emergency rooms and hospitals? I'm sure you all have stories of delayed treatment, out of control diabetes or blood pressure, or missed cancer screenings, and long-term impact of some of the adjustments that patients have made over this past year with delaying care. And then finally, I think of our nursing students and our practice readiness of our graduates as they enter into a workplace that is being adjusted and changed and challenged as well. And so what's the onboarding needs of the new graduates, and how do we come alongside and support them? So we've talked about a lot of things this morning, and I know next week we have a few more talks that are going to certainly shed some light into some of these areas. But so appreciate your attendance and all of the presenters and challenging us with some new ways of thinking and challenges as we move forward. And just as we move to Mo, I'm just going to remind us of our verse: be strong and courageous. Do not be afraid or terrified because of them. For the Lord your God goes with you. He will never leave you nor forsake you. Thank you for your attendance today.
Okay, just before Chaplain Morales closes out this session, I want to remind you that we are meeting again on next week, on the 27th and the 29th, from 5 to 6:30 on both of those dates. You have from 12 to 1 o'clock to go to the virtual posters, and you've gotten links for that throughout in various places, emails, and in the chats for today. Eventually, we'll have that added to the university website and so on. Continuing education, contact hours, there's 3 for your participation, for your evaluation of this session, and you can get 1 more for evaluating 6 posters for 4, so for a total of 4. And then the next sessions are each worth 1.5. So you can get a total of 7 for the conference as a whole. Chaplain Morales is a real friend to School of Nursing. He is our chaplain here at the Monrovia campus. He's also a personal friend of mine and someone that I have great respect for. Recently returned from a year-long deployment as a chaplain in the United States Army. So Chaplain Morales, if you would pray us out and provide a benediction for today, we'd be so grateful.
You got it, sir. Thanks, and everybody. It's so good to see over 500 participants today. So just, we're all in good company. So just remember, and I'm sure you've heard this a lot, but being on the front lines, you take care of so many. Don't forget to take care of yourself. And so with that, I'd like to pray for you and then leave you with the benediction. So if you would, let's go to prayer. Father, thank you for these men and women who have so graciously chosen to make a difference, not just in their lives or their families, but the lives of others. God, I pray that the things that they've discussed today, Lord, that you would really just bless them and allow them to take all of the knowledge that they've either given or learned, Lord, and be able to pass it on to others who are looking to them in their leadership and their expertise. So God, thank you for Azusa Pacific University and the God First mantra that we have and has been around for over 100 years now. God, I pray for the faculty and the staff and the administration, the leadership of this institution, of Azusa Pacific University, God, that you would continue to give them everything that they need to move APU to the next level. And God, for each of the men and women who are on this call today, I pray an extra measure of grace on their lives today. God, would you bless them? Would you bless their families and let them know that the work that they put into serving others does not go null and void, and it does not go unseen or unheard by you, Father, but that you are looking to hold them up and keep them in your fold. I pray these things in the name of Christ Jesus. Amen. And now, if you would accept this benediction, may the God of peace, who raised Christ from the dead, strengthen your inner being for every good work. And may the blessing of God Almighty, Father, Son, and Holy Spirit rest upon you and dwell within you this day and evermore. Amen. Thanks a lot, Dr. Wood.
Thank you, everyone, for attending today. We look forward to seeing you next week on Tuesday and Thursday. We continue to hold you in our thoughts, and we're grateful for your participation. Have a wonderful rest of your day.